Good morning and welcome everyone for joining us today for day 2 of the 83rd Presidential Advisory Council on HIV/AIDS, also known as PACHA, full council meeting. My name is Marlene McNeese. My pronouns are she and her, and I currently serve as the Deputy Assistant Director at the Houston Health Department, overseeing our Bureau of HIV, STI, and viral hepatitis prevention. If you were here with us yesterday, you know that we had an intentional, meaningful, and impactful conversation here in Montgomery, Alabama. We will continue those conversations here today. We did pack the agenda a bit. So I am hoping that we will govern ourselves accordingly and try to stay on task and on time because I'm excited to give all of our time and energy to the speakers that we have invited on some incredible panel discussions, as well as later today, the PACHA-to-the-People engagement session that we've made space for on the agenda as well. We do have some business to take care of today, so we will have some opportunity to get that out of the way, if you will, early on the agenda this morning. So with that, I will turn our day 2 roll call over to Ms. Carolyn Tallif.
Thank you. We'll start with our PACHA members. So PACHA Chair Marlene McNeese.
Present. I serve on all the committees and I hail from Houston.
Guillermo Chacon.
Present, co-chair of the Ending the Epidemic and also member of the Stigma Subcommittee. Thank you.
Philip Chan.
Philip Chan from Providence, Rhode Island, Brown University. I serve on the Ending the HIV Epidemic Subcommittee. Thank you.
Tori Cooper. Rania Copeland.
Rania Copeland, Equity and Impact Solutions Consulting, based out of Los Angeles. I serve as Stigma and Disparities co-chair, and I also am on EHE.
Mackenzie Copley.
Good morning, everyone. Mackenzie Copley. I lead 110 Health in Washington, D.C., and I'm on the Ending the HIV Epidemic Subcommittee.
Jennifer Cates.
Good morning, everyone. Jen Cates from Washington, D.C., KFF, and with Dr. Sullivan, I'm the co-chair of the Global Subcommittee.
Al Kawada. Duvia Lozano. Tiomi Luckett. Jesse Mylan.
Jesse Mylan, President and CEO at AIDS United, headquartered in Washington, D.C., a national organization, and I co-chaired the HIV and Aging and Long-Term and Lifetime Survivors Committee. Thanks to Diggs, and I serve on the Global Committee.
DeAndre Moore.
President DeAndre Moore, hailing from the South, from Texas, a PACHA member of the EHE subcommittee, and U equals U task force coordinator for Prevention Access Campaign, and AVAC board member.
Leo Moore.
Good morning, everyone. Leo Moore, Medical Director for Clinic Services, Los Angeles County Department of Public Health, PACHA member and co-chair of the Stigma and Disparities Committee. Thank you.
Laura Platero. Kayla Quimbley. Natalie Sanchez.
Good morning, everyone. Natalie Sanchez with UCLA in Los Angeles, and I serve on the Stigma and Disparities and EHE committees.
Patrick Sullivan.
Rollins School of Public Health, Emory University in Atlanta, and with Dr. Cates, I co-chair the Global Subcommittee, and I serve on the EHE Subcommittee.
Jeff Taylor.
Good morning, Jeff Taylor with the HIV and Aging Research Project, Palm Springs, and I'm the incoming co-chair for the Aging with HIV Long-Term and Lifetime Survivor Subcommittee.
Marvell Terry II.
President, Funders Concerned About AIDS, Atlanta, Georgia. I serve on the Stigma and Disparities Subcommittee.
Hansel Tukes.
Hi, I'm Hansel Tooks from the University of Miami, Miller School of Medicine in Miami, Florida, and I am on the EHE Subcommittee.
Carol Treston.
Good morning, Carol Treston, Association of Nurses in AIDS Care. I serve on the Global Committee and the EHE Subcommittee, in particular the Workforce Task Force.
Defina Ward.
Present, Defina Ward, Southern AIDS Coalition. I'm based in South Carolina. I serve on the Stigma Disparities and EHE Subcommittees.
Daryl Wheeler. Daryl Wheeler. CHAC Liaison Wendy Armstrong.
President, I'm Wendy Armstrong from Emory University and Grady Health System in Atlanta, and I serve on the EHE Committee and the Workforce Subcommittee Task Force.
Thank you. And before turning over to our federal partners, I will acknowledge Alicia Diggs, former PACHA member as of about 2 days ago. So Alicia.
Good morning, everyone. Alicia Diggs out of North Carolina, University of North Carolina at Chapel Hill, CFAR, Center for AIDS Research.
Thank you. Kay Hayes.
Yes, President, delighted to be here this morning. Deputy Assistant Secretary for Health, Infectious Disease, HHS.
Timothy Harrison.
President, Tim Harrison, Principal Deputy Director, Office of Infectious Disease and HIV Policy, Washington, D.C.
Francisca Ruiz. Francisca Ruiz. Adrian Shanker. Adrian Shanker. Brian Kaplan. Brian Kaplan. David Johnson.
President, good morning. Deputy Assistant Secretary for Health and Director of the Office of the Assistant Secretary for Health, Regional Offices, Washington, D.C.
Jonathan Jono Merman. Jono Merman. Robin Neblett Fanfare.
Good morning, everyone. President Robin Neblett Fanfare, Division Director, Division of HIV Prevention at CDC, coming in from Atlanta. Thanks.
Michael Carpin.
Good morning, Michael Carfin, Hersa Hab.
Good morning. Erna Hughes. Erna Hughes. Rick Haverkate. Rick Haverkate. Kristen Roja.
Good morning, Kristen Roja. I am the Public Health Advisor with SAMHSA based in Rockville, Maryland.
Thank you. Jerry Donnenberg.
Good morning. I'm Jerry Donnenberg. I am the Director of the Office of AIDS Research at the National Institutes of Health.
Jessica Lee. Jessica Lee. Michelle Schreiber. Michelle Schreiber. Amy Shivikas. Amy Shivikas. Tracy Carson. Tracy Carson. Andrea Callo. Andrea Callo. Casey Knopp. Casey Knopp. Maureen Goodnow.
Good morning, Maureen Goodnow, Senior Advisor at OIDP on detail from NIH in Washington, D.C.
Thank you. Sharon.
Good morning, Sharonda Brown, Deputy Director of Operations, OIDP, Washington, D.C.
Shannon Dowler.
Present, Shannon Dowler, OIDP.
Shari Jones.
Hi, good morning, Shari Jones, Office of Infectious Disease and HIV/AIDS Policy, Regional Director for 1, 2, 6, and 7.
Lauren Wagner.
Good morning, Office of Infectious Disease and HIV/AIDS Policy, Regional Director for Regions 3, 4, and 5 with the engagement teams.
Thank you. And I would like to quickly acknowledge two PACHA members, Tori Cooper and Duvia Lozano.
Duvia Lozano, Chicanos por la Causa, Phoenix, Arizona.
Thank you. And that concludes the roll call.
All righty. Thank you for that, Caroline. And we will go right into a little bit of PACHA business. As many of you know, much of the work is done within subcommittee. So these subcommittees have been working feverishly throughout the year to focus on priorities that were developed in tandem with community voice and community engagement. And so what we do as a PACHA membership is take the voices, needs, and concerns of our communities around the country and turn that into action, and really hoping to push and move the needle in federal spaces about the way these dollars and programs within HHS are managed and governed, hopefully to improve health outcomes across the country. So I'm really, really grateful for all of the members who spend an enormous amount of time and energy in these subcommittees working to turn that information into action. So we're going to hear from them explicitly. Extremely proud. I've been talking a lot lately about the work and the effort of our first subcommittee that we'll hear from, those aging with HIV, long-term and lifetime survivors. Again, you've heard from them already at this convening, but we will turn it over to them to talk about their activity and as well as any recommendations and updates. Alicia Diggs and Jesse Miley.
Thank you, Marlene. Good morning, everyone. Just want to first say that it has been truly a pleasure to work with Jesse and the entire team to develop this subcommittee, Aging with HIV, Long-Term and Lifetime Survivors. We have done some wonderful, wonderful work, and just really looking forward to the future, even though I will not be in this space, but I will be there in spirit. And But it has really, like I said, truly been a pleasure to really dig in to learn because I am new on the side of aging. So to hear the different things the different work that we are expecting to do and the different things that are coming down the pipeline, it's really going to be exciting. So I just wanted to say that it's been a pleasure. Keep your ears and your eyes open for some great work. And I'll turn it over to Jesse.
Thank you, Alicia. We will miss you, but thank you for all you've done. I am so pleased that Jeff Taylor has agreed to be the new co-chair. It should be official. Let's make it happen. And just a few updates from our committee. All of you received a copy of the letter that we've received from Secretary Becerra in response to our letter. And thank you all again for all of your support for that letter that we sent to Secretary Becerra on behalf of our committee, asking for three things. One, that he deployed the legislative office at HHS to support the reauthorization of the Older Americans Act, that he worked with CMS and the Agency for Community Living on securing a specific technical assistance project or program for helping people transition from private insurance to Medicare. And then third, that he asked the CMS and ACL to publicize the state plans on aging and how each state is responding to their mandate to support people aging with HIV. So that letter was a lovely response. And we thank him for acknowledging that he received it, but our advocacy will continue. So as you know, as you've already heard, there are many things that have not been reauthorized, and the Older Americans Act has not yet been reauthorized. So all of our work needs to continue. We encourage the community to continue to support that so that people aging with HIV will be included as a population of greatest social need. Second, we are thrilled that the Agency for Community Living has heard us and is willing to think with us on how they can make it possible for people aging with HIV who are moving from private insurance to Medicare to get the resources through the SHIP program. And we especially thank the Ryan White program and our good friend Michael Caffrin for understanding that he may already have case managers who are doing that, but many people don't know that. So working with those two together, and they came together in our last meeting. So that's a wonderful new collaboration that we hope will continue and expand. And we thank both Andrea and Michael for that. And we thank the Agency for Community Living for also agreeing that they think it's a good idea that the state plans be reported to the public to show exactly what is happening with regard to those plans, including people living with HIV and aging with HIV. She's warned us that all of those plans are on different time frames, and so it might have to be a rolling process, but we are happy to continue to work with ACL on how those would happen. My new co-chair and I have met, and we are looking at some major new priorities for our next year. And those are really focused around quality of life. As we've heard, those quality of life indicators are so important. And we want to make sure that in terms of aging, we look at three. One is long-term care for people aging with HIV. Long-term care is different than just housing, because any of us who have put parents or grandparents in assisted living, we know that long-term care is a different medical model. And so as people are aging, especially as so many will be turning 70 by the end of this decade and more, Resources and strategies and programs for long-term care is a priority we will focus on. Second is financial security for people aging with HIV. We, as Jeff has made very clear, so many people have had to divest themselves of all their resources as they've been aging, but as they get to 65 and older, their ability to maintain their financial security seems very, very precarious. And then third, we've already been working on clinical care, and so we're looking at how the best practices for clinical care for people aging with HIV, screenings for frailty and screenings for dementia and Alzheimer's and cognitive issues, as well as kidney and liver, all those things that we've heard about in terms of quality of life. We're going to continue working on those, how we can make sure those best practices are not only within the Ryan White program, but with all providers who are treating people aging with HIV. So that's our agenda.
So briefly opening it up to any PACHA members, obviously inviting federal colleagues. If you have a question or comment for this subcommittee, please raise your tent. I know that Michael Carfin is online. I don't know if you had any additional comment or question.
Just to say that we're very pleased to work with the subcommittee, and HRSA HAB has really made aging with HIV as more than 50% of people with HIV are now over 50 years old. So, and we're grateful for the collaboration with Administration for Community on Living and growing our partnership with CMS, HUD, and other agencies to address the needs of both or among people aging with HIV, including the Dandelions or lifetime survivors.
Thank you, Michael.
We are recruiting new members. We are recruiting new members, and we do hope that we can collaborate with the workforce subcommittee on best practices in clinical care. Sure.
Yeah, just a couple of things. When we talk about aging with HIV, we need to remember that it starts about 15 years earlier, so that when working with our federal partners, seeing if we can get carve-outs to lower that age for aging services to 50. And then, of course, we're delighted that Jerry Donnenberg is now director of OAR. We look forward to working with her on some long overdue research needs that have been unaddressed for far too long. Thank you.
All right. As I said, they have been working feverishly in their inaugural year. And again, just can't say enough about all of that important work. As many of PACHA members know, we've spent a lot of time hearing back from community about the needs of people aging with HIV. And so I am so grateful for this committee and their work on pushing some things forward and these new partnerships. So thank you. And we will move on. Next, we have Ending the HIV Epidemic Subcommittee, our very own Guillermo Chacon and Tori Cooper, who co-chair that subcommittee together. I will turn the floor over to you two.
Good morning again, everyone. As you can see, I am double booked. So my apologies. No one in this room can relate.
Only you.
Yes. So I will briefly go over some of the notes from our last meeting, some of the things that we discussed in our last meeting, and some of the priorities we've been working on this year. We have provided impact and input and feedback for an in-house statement and resolution that we're putting forward. Also, had a discussion about climate change's impact on health equity, and I think that's really important. Often in this line of work, we don't talk about the impact of public health, but when we think about places in rural communities, traditional farming communities, that's always an important conversation to have. Some of the talking points were about evaluating the delivery of HIV services, and part of this conversation was as a direct result of Helene, who hit Asheville, just a few days prior to our meeting at HRC, at the Human Rights Campaign. We had a leadership development program, and one of our cohort members, she's actually from Asheville, North Carolina, and she had just gotten electricity back about a day and a half before she was due to fly to Atlanta. And so what we did was we had to work around, we had to somehow figure out how to get her to Charlotte to get her to an airport with no running water and all of those other things. And so many of us, I guess, had never thought about how that could impact our service delivery here in the United States. We think about it in third world countries, but we don't think about that it happening places that are supposed to be leaders. We also talked about engaging federal agencies, including FEMA and some other things, and also the private sector. Some of the conversations that came up was how can we encourage federal agencies to provide, to do drops of medicine, if you will, to ensure that people will still have a continuation of their treatment, even if it's for prevention, because unfortunately, one of the commodities, one of the businesses that comes up after federal emergencies is sex work. And there usually isn't a great influx of condoms after that, and certainly not of injectables for prevention. So we wanted to make sure that we could get folks, and we had something in line for when the next big thing happens. We also talked about workforce, and we're really thankful to our workforce subcommittee for the thoughts and the works that they're putting in. And a conversation that comes up all the time is about the roles of nurses and nurse practitioners. They're so important to our healthcare. And really, I think, undervalued and undernoted. We always talk about how great our doctor is, but rarely do we say, you know, we spend much more time with our nurses and MPs than we do our doctors. So thank goodness for them. We also talked about some of the addressing evolving linguistic and cultural needs of Latina and other minority communities, and even just the term Latina. How folks who are of Hispanic and Latin descent have to determine what words we use to describe their communities for themselves, and improving support for free and charitable clinics as well, how building up that infrastructure and really providing them some more of the tools that they're going to need moving forward. A conversation, Mackenzie, I think, is the one who usually brings this up. So how wonderful we're sitting next to each other. It's about the Paperwork Reduction Act discussion. And we had a bit of a discussion around that. And also addressing that with some of the work that we do, we need to decrease barriers to real-time data collection, period. We also talked about funding equity and access to resources, and that means increasing opportunities for CBOs and for people who are just doing the work, whether they're connected to a CBO or not. Some of the most powerful work are folks who are independent operators or independent consultants, or just do it out of the kindness of their hearts. As always, we talked about this as social determinants of health, housing, mental health, substance use services, and specifically for communities with more intense disparities, including, again, MSM communities, Latino communities. I would be remiss if I didn't say Black and trans communities, or trans and Black trans, and et cetera, and then focus on dismantling stigma, homophobia, transphobia, and xenophobia. Anything else you'd like to add?
Thank you, Tori. And because we end in the year, we, on behalf of each member of the Ending the HIV Epidemic, Tori and I, we want to say thank you to Caroline, Chloe, and, because without you, I mean, that's the way to do it. A partnership and working together. Also, we want to recognize, Tori and I, we want to really recognize Dr. Armstrong. She has been a force as a liaison with the CHAC, and her leadership on the workforce and the way that Tori described it is the way to go. We truly want to acknowledge each member, and obviously we're very proud that we also entertain and educate the subcommittee, and then we brought a couple of initiatives regarding the risk adjustment model, to trying to increase accessibility to PrEP. But again, on behalf of each member of the subcommittee, we want to really recognize the support that the entire PACHA and our federal partner has been providing to all of us. That's it. I don't know if anybody else want to add anything, but thank you. Yes, and also we will be entertaining some resolutions in today's meeting, and we're looking forward for that. Thank you.
All right, any comments or questions for Ending the HIV Epidemic Subcommittee? You covered it all. It's a lot. And again, thank you all for your leadership on that. I know it's been an active season for you all as well, especially in light of bringing forth this particular resolution and looking forward to, I believe, probably and likely next meeting, hearing more from the work group around the workforce. So thank you for your leadership, Duvia and Dr. Armstrong. Looking forward to that. All right. Okay, let's move on. We have Stigma and Disparities Subcommittee, chaired by Dr. Leo Moore and Rania Copeland. I'll turn the floor over to the two of you.
Good morning, everyone. We've had a very active time in the Stigma and Disparities Subcommittee. We started the year off with an in-person planning retreat, and we came up with 3 priority areas that we thought were going to be important to make a dent in when it comes to reducing stigma and disparities. So our focus includes PrEP, and what does PrEP increases look like and efforts for that. You're going to hear from each of our 3 work group leads talk a little bit about the work that they are doing. So a focus on PrEP. We have another focus on HIV criminalization, and that criminalization has expanded. So a lot of it had been focused on molecular HIV surveillance, but thanks to some of the other subcommittees, particularly HIV and aging, they brought up, for example, criminalization that happens from birthing parents when they want to chest feed, birthing parents who are living with HIV. And so that's something that we're considering now as well. And then we have a stigma disruption work group, which has been doing some really kind of amazing work. We tasked them. They were charged with thinking about, how do we really make a dent in stigma? I think I talked a bit about this yesterday, how we talk about stigma, but what are the actual kind of ways that we disrupt it? How do we end it? How do we actually name it? And so we're really excited to bring forward a resolution today that we think is going to be game-changing with how we're trying to end HIV, particularly how we define and do work towards stigma, and how organizations across the country, particularly in EHE jurisdictions, should be able to have this different pathway to be able to be responding to have resources for stigma reduction, stigma disruption. So I will hand it over to my co-chair, Leo, who will then hand it over to our work group leads to talk a bit more about the work that's been happening.
Thank you, Rania. So first, I'll just mention that we are in this committee, both Rania and I have been really focused on ensuring that all of our work groups are providing updates regarding the work that they're doing. And so on December 17th, next week, we'll be having a 2-hour stigma and disparity strategic planning session where we will kind of take an inventory of where we are and our goals for the next year. We also have an in-person meeting every year. So we're in the planning process for that for 2025 as well. I will give the updates for the HIV criminalization and discrimination work group, for which I am the interim chair for that group. So on November 18th, we met with Positive Women's Network, Zero Project, and the Center for HIV Law and Policy. And this was a meeting requested by those groups. I think it's really important for all of our committees to hear from community. And so we always welcome the opportunity to meet with community groups. And so there's continued concern regarding the use of molecular data without consent of people living with HIV. There's also continued concern for potential criminalization of people living with HIV and the inability to protect the release of molecular data to law enforcement. And so we have committed ourselves to having a follow-up meeting with CDC in 2025. As many may recall, we met with CDC and other groups about 2 years ago regarding CDR and MHS. And we also passed a resolution as well about a year and a half ago. So we will continue to do this work, continue to meet with the CDC and to advise in our role. With that, I will turn it over to Natalie for PrEP work group updates. Thank you.
Good morning, everybody. So our PrEP work group, we meet monthly, and there's 2 things kind of on our agenda, is looking at making PrEP access available to all communities, so addressing disparities, but also access related to injectable PrEP. And so, as you know, my question yesterday was looking at how we're tackling prior authorization. So even though there's access and new policy to make sure we roll out and make these available, there continues to be barriers, and we continue to hear from community members that it's making it extremely difficult for implementation on the medical side, but also for the clients and waiting for those prior authorizations to go through. So those delays then lead to new infections in some cases. The other piece that we also recognize is that PrEP education information still needs to be out in the community. And so we're continuing to look at the development of a PrEP Awareness Day. And in our meetings, we've communicated with a variety of different community partners to make sure that they're on board, that this is something that the community wants. And what we're hearing is, yes, that there's not enough information or on PrEP and the different types of PrEP. So hopefully by next year, we'll be able to identify a day and then be able to roll that out with community partners. And also we're doing that in collaboration with HIV.gov.
Good morning, everyone. In the Stigma Disparities Work Group, we too are meeting on a monthly basis, and our focus is really around how we upend stigma as a barrier, recognizing that it is fluid and in the context of discrimination and bias. And so the first thing we charged ourselves with was to define stigma disruption through a lens that agitates systems and policies that perpetuate these acts rather than on the backs of people who suffer under stigma, because the people are not the problem. And too often we frame stigma that way. So our work this year, we had 3 priorities in addition to our definition of stigma disruption, which we have worked together to create. We also wanted to see how we could go about identifying strategies to address stigma in the context of the EHE and how we could ensure that stigma eradication is identified as a critical component towards our goals of ending the epidemic. And we're excited about the resolution that's going to come forth later today that will address that. Also, a priority that we're taking with us into 2025 is examining how HHS, federal agencies, and partners have implemented previous recommendations from PACHA around addressing stigma and identify strategies to ensure the recommendations that are previously made, that they don't fall to the wayside. And we can see how those things might be updated as well. So that's the work that we're doing. I just want to repeat the shout out to Chloe and Caroline for all of the diligence and emails and meetings that you've helped us to coordinate. And thank you so much to the work group and to our subcommittee leadership for all your support. Thank you.
Maybe I would just say one other thank you to the subcommittee as well. I know that Leo and I, we drive, we drive hard. And so we've had lots of meetings, we've done retreats, we've put people to task. And so we welcome new PACHA members or PACHA members currently who want to join and get put to work in the Stigma Disparity Subcommittee. We have a long legacy of impactful work. I think some of the chairs of this committee in the past have been amazing leaders when it comes to stigma reduction. And so looking forward to new people because we have so much to do next year.
Yeah, y'all can give them a round of applause. They do indeed drive very far, as you've heard. We'll be meeting next week. But wanted to really express my thank you to the leadership. You've had lots of turnover, if you will, in that committee, but you've kept the train going. And I really, really appreciate your energy. I also wanted to thank the rest of the PACHA membership for your sort of recommitment to the work. I think now more than ever, moving forward over the next 12 months will be critical, as we've heard a lot already about the gains and the successes that we've been able to make. It will be extremely important to not let up on the push and the pressure toward the continued effort that needs to happen for our communities. And I really wanted to say thank you to Natalie and her leadership around PrEP and PrEP implementation and some of the challenges that we know. I mean, we all know that when we do have new technology implementation, that oftentimes doing that business the same way without having some intention around inclusivity, we leave communities behind. And the idea that the focus across all the committees, quite frankly, for stigma and disparities, EHE, aging, we're really honing in on making sure that we are not leaving people behind. So I just wanted to say thank you to all of your work and appreciate that. But I will open the floor for comments or questions from any member. as well as any of our federal colleagues and partners. I just knew CDC may take the opportunity to brag about the new PrEP funding that's gone out across the country. I think it will be a game changer. As one of those funded jurisdictions, I'm extremely excited that we get to work with community in whole new ways to ensure expanded access to PrEP for Black and Latino women. So excited about that. So I don't know, Dr. Fanfare, not to put you on the spot, but if you wanted to say any more about that.
Thanks so much for that setup. Yes, I think, we were really excited at the very last day of fiscal year 24 to be able to use $10 million in EHE money to send directly to 5 jurisdictions, one of which is Houston. Then we also have Baltimore City, South Carolina, Florida, and the state of Oklahoma. As we know, PrEP is game-changing, life-saving. It's been FDA approved now for more than a decade, but substantial geographic, gender, racial, ethnic disparities still exist. And so really thinking of ways, as people are talking about, that these jurisdictions can be disruptive, can be innovative, can be creative to really help increase access to PrEP. So we're really proud of that and look forward. And I know a lot of people are looking forward to what these jurisdictions are able to accomplish and how they can serve as a template and a blueprint for the rest of the nation moving forward.
Thank you. Anyone else? Okay, we will turn it over to our global subcommittee, Dr. Jane Cates and Dr. Patrick Sullivan. The floor is yours.
Thank you so much. Now I will give my global update. Just as a reminder, as part of our charter, included in the charter of PACHA is to give input and information and advice to help the Secretary in providing global leadership and responding to the HIV pandemic and expanding access to treatment, prevention, and care for people living with HIV or AIDS around the world. So it is part of what we are charged to do. And on our subcommittee, one of the ways we try to meet that goal is to provide updates at every PACHA meeting about what is happening with the U.S. response to the global HIV epidemic, as well as ways that we can bridge the knowledge and learnings globally with our domestic work and vice versa. So I'm going to start actually first with a reflection, which is that since I do both global and domestic HIV work, last month I was very honored to be able to go to Malawi for a site visit to see how the Global Fund, for those who don't know, the Global Fund to fight AIDS, TB, and malaria is an international multilateral organization that the U.S. helped create and is the largest supporter of. With PEPFAR, the two together are the HIV backbone of the world for low and middle income countries. So I was able to go to Malawi and see firsthand the impact of those programs, which is very, very powerful, and to be able to do that. And a few observations. Malawi is a very low income country. There's a high HIV prevalence, and there's lots of challenges in Malawi. There's been flooding, you might have in the last few years, but there's also been droughts and there's food insecurity, lots of challenges. At the same time, Malawi has reached 95, 95, 95. It is amazing. And having met many of the people on the ground who are doing the work, there's so much resilience, so much excitement and hope, and just lots of innovation. So fast forward to here, the month later, and now I'm in Alabama, a wonderful state that also is challenged with many of some of the similar. I should have said Malawi is almost entirely rural. So Alabama's a rural state. Alabama has income and food insecurity challenges as well, but so much resilience and so much hope and energy that I've seen. So it's just really, it's a nice bookend for me. But I also wanted to give a shout out to Kay, because Kay Hayes was the person behind this idea that PACHA should go to the people, and that we should go out of DC and see programs on the ground and understand what the work really is. So thank you, Kay, for doing that, and Carolyn for continuing to carry that forward. A brief update since our last PACHA meeting, where we did devote some time to the global response. I wanted to just let everyone know that in September, there was a very important meeting that the National Academy of Medicine organized and sponsored to bring together leaders on HIV to talk about sustainability of the HIV response globally. Report from that meeting was published on the National Academy website. I'm happy to, we'll share it. In addition, PEPFAR released its World AIDS Day results earlier this month, and I'll just provide some highlights. Since 2003, when it was created, PEPFAR has estimated that it's helped save 26 million lives, kept 7.8 million babies born HIV-free, is currently supporting 20.6 million people on antiretrovirals, helped enroll 2.5 million people newly on PrEP in the past year, is supporting directly 342,000 healthcare workers. And this is in the 55 countries in which PEPFAR operates. Looking ahead a little bit, there's a couple of important things on the horizon that our subcommittee will monitor and bring to you. One is that PEPFAR has been working very hard to develop sustainability plans with its countries, meaning looking ahead and trying to put in place plans with country partners and governments to sustain the HIV response over a long period. Because while the US has been a very generous supporter, it's not likely to always be there. And so, and countries themselves need to take the work forward. In addition, as those who have been on PACHA for a while and others know, PEPFAR is due to be reauthorized for another 5-year period. Its current reauthorization is a 1-year reauthorization only, and it ends in March. And so there's an open question as to will it be reauthorized at that point? Will there be a delay? But we're continuing to monitor that. And I know that the PEPFAR itself is pushing for a 5-year reauthorization, as are many in the community. And we'll give updates as soon as we know them, and probably at the next PACHA meeting. Patrick, anything to add?
Thanks, Jen. The one thing that I would just put a name on that you've sort of alluded to that we talk about is bidirectional learning, which I think is acknowledging the innovation and programs and even clinical trials that are happening in other parts of the world that have impact for what we do here. And so maintaining those relationships and being interested, being present to know what's going on in the rest of the world and to share what we've learned. And I really appreciate, PACHA's highlighting this component that really is part of the US government's presence in the world, but is also a benefit to us to learn from what's going on in other areas. And I think we talk about that regularly on our calls, just about what we can learn. And we hope to continue bringing that back. Thank you.
Go ahead, Carolyn.
Thanks. I just wanted to flag that we did share an article that Dr. Cates wrote. The ground has shifted under PEPFAR. What does that mean for the future? And I did want to flag that it's in the binders and on the table for members of the public in the form of a QR code. So I just wanted to flag that. Thanks.
And I too just wanted to send a thank you yet again to Jen and Patrick. Our last PACHA meeting really was a master class in learning from many of the originators of the global response and how those lessons learned still are applicable today, how the US response is a part of the global response, and really helping us to see and learn those things that are indeed working across the world, and how we can apply that here in our country. Dr. Tukes, I see your tent.
Thank you. A really amazing update. And that sustainability workshop at National Academy was just a phenomenal day and such success for PEPFAR. My question is, are you all going to make any recommendations as it relates to lenacapavir, given the results of the PURPOSE trial with the efficacy in African women, to ensure the equitable implementation and distribution in Africa?
Well, PEPFAR itself has already come out and said it's making plans to support that rollout. And so from everything I've seen, they're ahead of the curve. They're really pushing to make sure that that happens as soon as the appropriate approvals and regulatory steps are in place. Since we're not there yet, but I believe purchasing arrangements are going into place, and the program is committed to scaling that up. But we'll monitor it, because obviously it's one thing to announce those things. We want to understand how it rolls out. Yeah, thanks.
Anyone else? Well, thank you. Let's give a round of applause to Jen and Patrick. Moving on in our agenda, we are going to hear from Dr. Armstrong, who serves as the liaison to the CDC HRSA Advisory Committee on HIV, viral hepatitis, and STD prevention and treatment on behalf of PACHA, who's going to share a little bit of update with us here today. Thank you, Wendy.
Thanks so much. I will try and do this succinctly. It was a very rich meeting, October 21st and 22nd at HRSA. As you all likely know, we flop between HRSA and CDC as sites for the meetings. And so this was a meeting that is organized by HRSA and a little bit more focused on issues that are pertinent to HRSA. There were two major themes to the meeting, I think. One was our federal partners giving updates about the success of EAG. And then secondly, woven throughout the whole meeting was this notion of Ryan White 2030, which is the idea that, or the focus on how do we get the 10 to 15% of individuals who are not engaged in care or retained in care into care, and what are the steps that we need to do to get there, given the success of Ryan White for the population who's in care. Just to quickly give a brief update from the federal partner updates, and I won't spend too long on this, but again, the highlights were an EHE success. HRSA discussed or noted how in 2022 in EHE jurisdictions, 22,000 clients were new to care and 19,000 were re-engaged in care, which was nearly double the results from 2020, to show you the impact. They also have launched efforts, so grant opportunities for programs to develop system-level syndemic approaches to improve care for racial and ethnic minority groups, to support people with HIV as leaders in HIV systems of care, which AIDS United is taking the lead on. Thanks, Jesse. And for HIV clinical training tracks for primary care residents at locations that do not have HIV-specific training for their primary care residents. And so those are exciting opportunities. The Bureau of Primary Health Care, again, highlighted the success of EHE in the health centers. They have grown their funding to health centers through the primary care HIV prevention funding from about $50 million in 2020 to $157 million in 2023 and 2024, with 411 awardees, with clear evidence of increased testing, increased PrEP management services, increased diagnoses, increased patients served. And ultimately, those health centers that got primary care HIV prevention funding provided 80% of the PrEP services in the health center programs and reached 16% of all PrEP users. Dr. Merman gave the CDC update. Again, a focus on EHE with more than 600,000 HIV self-testing kits distributed, more than 1 million HIV tests with 4,600 newly diagnosed, more than 61,000 patients on PrEP. They connected and worked with 329 syringe service programs. About more than 50% of those were mobile. There was a discussion of implementation of point of care tests for syphilis, and that is something people are grappling with, as well as how to roll out and use the first point of care HCV RNA test that's available. And again, highlighted the HIV prevention awards in sexual health clinics as a syndemic approach. We then moved on really to the panels. And like I said, this was very, very focused on how do we reach that 10 to 15% who remain out of care, leveraging partnerships, focusing interventions, and utilizing community engagement. And so there were 4 panels. The first looked at data to care strategies to re-engage people with HIV out of care. And what this was really about was how do we optimize existing data sources and how do we find innovative data sources? And what came out of this, and it's a little bit of it is above my technical knowledge, that what was clear was that using multiple data sources in a combined effort actually gave better results. And by this, I mean not only things that make sense to all of us, like DMV data and vital statistics and deduplicating individuals, but using these web scraping techniques that actually harvest off of the web in existing rosters and things like that. And there are a couple different code softwares that people are using. And if you put them together, for example, you got better results than if you used anything individually. And that's where the part that's above my knowledge is web scraping. But at any rate, the results were really remarkable using sort of multiple integrated disease surveillance systems. And then there was data, again, showing other systems like collective medical technology using data from Epic or the electronic health records, jail bookings using a program called JB Link, pharmacy records, other publicly available records. And the bottom line was that this helped, and there were, in particular, Julia Dombrowski from University of Washington showed real life examples of how this helped find patients, make lists that were accurate and of a size that was approachable. And so, for example, using some of these techniques of a group that were presumed to be not in care, less than 20% were actually not in care. And so that's a much easier group to focus on. A third of those patients ended up linked and 63% were virally suppressed in 6 months. And so these strategies to sort of refine finding patients not in care or identifying patients not in care in order to use the innovative models to support them was impactful. The second panel was talking about long-acting injectables, and the long-acting injectable work group, of which Shannon is the chair, had identified a need to hear the lived experience from individuals with long-acting injectables, and we're particularly interested in people in people who are started with viremia, who had achieved viral suppression for the first time using long-acting injectables, or individuals sort of in other minority groups. And so there were 5 individuals who are on long-acting injectables who were this panel, who were the members of this panel, and talked about why they started. For some folks that worked in the healthcare system, it was also to be able to experience this, to actually be able to interface with their own patients and so on. But there was one patient who was really underweight, dramatically underweight with opportunistic infections, and had years of attempts to help her find success with oral therapies. And she talked about really how life-changing this was, and how she is gained 20 pounds at a relatively recent start, and was able to run somewhere again for the first time and begin to envision a different life. And so this, I think, really touched a lot of us in the room, and was another strategy to think about how to reach that 10 to 15%. The third panel was on increasing access to mental health services for people with HIV and STDs. And this highlighted the massive mental health service access gap of 100% of individuals with mental health concerns. Only 20% were engaged in mental health care. Talked about training events through the AETCs, talked about evidence-informed interventions, particularly around collaborative care management, incorporating behavioral health and psychiatric or consultants or psychologists with PCPs to improve both the mental health continuum of care and the viral continuum of care, and quality of life. There were 4 or 5 new programs that were called out awaiting results. One of those was Dr. Eaton's here in Alabama, looking at screening and telemedicine delivery of treatment services for mental health and substance use disorders at Ryan White sites in Atlanta. Another was for low barrier care in low barrier clinics for the same mental health and substance use therapy in Washington. There were others for breaking systemic barriers for trans women of color, using telehealth and peer navigation. One was an AI chatbot. If you have conversations with an AI chatbot, can that actually be supportive? And so again, some really creative and different ideas. And then the final panel was on overcoming barriers to re-engage people with HIV out of care, understanding the barriers and expanding the reach into the community. And I think the highlight of that panel was a very small pilot program by Whitman Walker with that they called the MORE program. It's a mobile outreach, retention, and engagement, doing home visits. And what they showed with this very small pilot was the group getting home visits were less likely to be lost to follow-up than the controls. And if you were retained in care, obviously you had, not surprisingly, you had more likely to achieve viral suppression. But what they were rolling that into is home visits for long-acting injectables. And so that wasn't, they didn't have data on that yet, but that's, I think, again, a really exciting application about how to get care into the community. Finally, we approved and sent a lifetime survivors letter to the secretary to encourage including lifetime survivors in HIV-related programming, but also to in both research initiatives as a research focus, but also as a separate category in studies and surveillance, so that that differences in outcomes, et cetera, for lifetime survivors can be tracked differently from individuals who of a similar age or aging with HIV that have had a different lifetime experience. Establishing models of care and centers of excellence for lifetime survivors, and developing a strategic plan to address unique needs, health outcomes, and quality of life for lifetime survivors. And then lastly, we started 2 new work groups. One to look at reimbursement for point of care and self-testing, particularly around viral hepatitis and STI testing. And then secondly, to think about what payer levers there might be to optimize ancillary services for non-Ryan White funded support services that may include linkage and navigation in settings where Ryan White funds aren't available for that, but also for STIs and Hep C and so on. So that was, I think, the summary of a very rich meeting. Thank you for sticking with me.
I believe I speak for everyone. That was a very excellent and detailed summary. I felt as though I got all of the highlights from that convening. So thank you so much for your service, Dr. Armstrong. Any questions or comments for Wendy? Go ahead, Guillermo.
I just want to echo that in how outstanding is, and for the audience, to know that CHAC and PACHA are, like two strong arms, I think, from a federal response, and how amazing is to hear, that is not only a detail, but also give us perspective to continue this journey and advance as much as we can from the cities, the counties, the state, the territories to end this HIV epidemic. And I really want to say thank you to the tremendous commitment of Dr. Armstrong that, she honored her last name for sure. Thank you.
Jerry, please go ahead.
So I've only been in my position for 2 months, and I'm very grateful to be here. And as I listen to all of these recommendations, I keep wondering, how does OAR intersect with each of these recommendations so that we can drive the research to address these? And I think, I'm finally compelled to speak about this, given Dr. Armstrong's presentation. And I'd like to hear how, at least in the past, that might happen, or some suggestions in the future. I don't know if, someone from my office should be represented on some of these work groups, because I think some of these recommendations are so powerful, and we don't need to recreate the wheel, in my office. We should be drawing on what you all have been accomplishing all this time as we think about the next, particularly implementation science questions, because that's my bailiwick. So any comments I would welcome.
Thank you for offering, and I certainly would invite PACHA members to chime in if you also have thoughts, recommendations, and needs. But I would say that in my time in and around the PACHA table, we've had a great relationship and connection with OAR, and certainly know the value and the importance of partnership and that collaborative approach to the work that we do. So I'm grateful that you're here today with us in Alabama, and hope to see you routinely and often in all of the things. And the idea that there could be participation on subcommittee work is vital. I would say that's a resounding yes, 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 yes. I can see all of the wheels turning from all of our subcommittee co-chairs. So I think I speak for everyone to say that, yeah, we'll be in touch. The need is there. I see Caroline and I see DeAndre.
Thanks, Arlene and Dr. Donnenberg. I'll say, when you were announced, I know our HIV and aging subcommittee was like, let's invite her right away. I will say, when we get back to DC next week, Chloe and I will connect with you to share more information about each of the subcommittee and ongoing participation, and echoing everything Marlene said, because I know all the PACHA members are so happy with your comments. So we'll connect when we get back. Thank you.
Thank you. That was such a great update. We were saying we felt like we were there, which is a great way to be a liaison. I just had a question. PACHA was in DC sometime this year. We had the opportunity to meet with Whitman Walker, and so we heard a little bit about the mobile clinic. And then we were here and did engagement visits, and we heard about the model that Five Horizons was using for how they do kind of like mobile visits. Obviously, each region is very different, but my question to you is, do you remember if they have the visits inside the home, or do they have people come to the mobile unit, just to understand like the context and how it might be different?
Yeah, they had visits in the home. They had a kit that they would take with them into the home and conduct the visit there.
Yeah, I just think it speaks to how different our country is in different places, and you really need to have a tailored approach. And I think Five Horizons did a great job explaining how their kind of mobile process brought people to the health department. They picked them up, but that they didn't have the space, and really privacy was an issue, and stigma was an issue. And so I think it's just interesting to think about how in different locations you really have to have a tailored approach. So thank you for that.
And Rania looks nothing like DeAndre, so
You said it's Riandre.
Okay, perfect. So with that, are there any other comments? Okay, thank you so much, Dr. Armstrong, yet again, for sparking such lively discussion. And I think there's a lot more to come. We do have scheduled on our agenda our opportunity for public comment. We do in advance offer the opportunity, as our meetings are public, for the public to be able to engage and share thoughts and comments with the PACHA team. I don't know if we have anyone signed up today, but I'll turn it over to Caroline.
Thank you. And yes, we do, for folks in the room who have registered for public comment. Just a reminder, there's 3 minutes. Chloe will have time cards that say when there's a minute left and when we're at time. We have our first virtual public commenter. First time, last minute, he was not able to attend, so it is pre-recorded. Mark Mizrak, Executive Director of the National Working Positive Coalition. Damon, thank you.
My name is Mark Misrock. I use he and they pronouns, and I'm the Executive Director of the National Working Positive Coalition and a member of the U.S. People Living with HIV Caucus Steering Committee. I've asked to address you about the extremely high rates of people living with HIV who are both not employed and are living at or below the federal poverty level, and the virtual absence of any federal response to the employment-related needs of people living with HIV for information, services, and resources. The CDC this year released their latest MMP report on data collected in interviews with people living with HIV in the US from June 2022 through May 2023, showing 35% of people living with HIV not working, and showing 33% of people living with HIV living at or below the federal poverty level. This body, PACHA, the CDC, and the HIV/AIDS Bureau at HRSA have helped advance extraordinary biomedical responses, but there's a dramatically underdeveloped response to the non-biomedical impacts of HIV on our lives. These include widely ignored, severe and entrapped poverty, and the extraordinary rates of unemployment and underemployment. Currently, neither HRSA's HIV/AIDS Bureau or the CDC have any initiatives acting on this information, either directly or through meaningful partnership with other federal agency employment-related initiatives. In the HIV/AIDS program, a paralyzing ban begun in the 1990s continues on use of Ryan White HIV/AIDS program funding to address employment needs or job readiness needs. Compounded by the Department of Labor and the Department of Education avoiding any involvement, and without concentrated focus by PACHA, this stalemate sends hundreds of thousands of people living with HIV into unending poverty and social marginalization. Our ask is for PACHA to plan in their soonest possible meeting an agenda including concentrated focus on better understanding these issues, challenges, and potentially available solutions, which we could help develop. Thank you.
Thank you. So next commenter, we have Robin Webb, People Living with HIV Network Director from the We, the Positive Southern Network, My Brother's Keeper.
Thank you. Thank you. Good morning, PACHA members and observers. My name is Robin Webb. I have lived with AIDS and HIV for 4 decades. I'm 67, born in 1957. I currently live in Cleveland, Mississippi, home of Michael Felton, and 8 miles to the east is my boyhood hometown of Ruralville, Mississippi, same as Fannie Lou Hamer. As a young boy, a young gay boy, mind you, gay from day one, I remember Mrs. Hamer very well. She and Pap lived only a few blocks away, but a universe apart, given our difference in age and skin color. From a sheltered white distance, I remember crossing paths with Freedom Summer volunteers of 1964, Freedom Schools, Med Grubbers, Bob Moses, M.Z. Moore, Florian and Joyce Ladner, Charles McLaurin, who I still know and visit with, Joyce Collier, and even Dr. King once when he visited Sunflower County. I remember SNCC activists and their civil actions. I do not remember Ella Baker. But let me ask, if Ella Baker were to talk among us, to walk among us today, specifically in the HIV world, especially in the Mississippi Delta, will she ask us where or who is our modern day SNCC? For instance, given my 10,000 sisters and brothers living with HIV in Mississippi, the over 50,000 people living with HIV in Mississippi, Arkansas, Louisiana, and Alabama, or among the hundreds of thousands of people living across the South who never benefited from the early AIDS urban empowerment movements, why can't we name any South-specific PLHIV-led, PLHIV local and statewide networks? The kind of on-the-ground movements that are group-centered, open to all organizing of the masses, as opposed to leader-centered organizing of the funded few. Why can't we name them? Because they don't exist. Why do we have thousands of PLHIV in the Deep South who cannot tell you what HOPRA or Zoom or U=U or HIV decriminalization means? Icons of my boyhood who walk the same ground and breathe the same air as I did might pat our HIV work on the back, but I do not believe they would be 100% pleased with us. Not yet. The next wave of intersectional advocacy must be organizing and engaging Southerners living with HIV/AIDS, not just a half dozen cherry-picked tokens are not, but all of us on a massive scale who are subject to other disparities and injustices, so that we may be prepared to defend ourselves moving into 2025 as a PLHIV Southern stronghold with response teams, pressure groups, disturbers, influencers, activists, and amplifiers when the next wave of dark politics tries to carve away at our quality of life. And they have already started. For just one example, Mississippi's Medicaid expansion movement is outmaneuvered by what I call Mississippi's Medicaid contraction movement, throwing 30,000 of us off the rolls, reducing Medicaid to bare bones, expending our energy and resources putting out fires as opposed to igniting fires. My call for us, all of us, is to put our brilliant brains together and get this mass organizing done. Please hear me. This is absolutely doable. There are clear, measurable, and affordable solutions to accomplish this. For large organizations in the HIV/AIDS world, please understand that we understand it is not your role to fix us.
Mr. Rapp, thank you so much. But in order to respect other people that have signed up in time, and we'll ask if you can submit your comment written, and we'll include it in the written record. Thank you. Tom Daniels, I'm Director of Government Affairs at the HIV and Hepatitis Policy Institute. Thank you.
Good morning. I'd like to take this opportunity to thank PACHA and the Biden-Harris administration for their support and leadership over the past 4 years. People living with HIV are continuing to face challenges in accessing life-saving medications, which mitigate the harmful effects of the virus and prevent the transmission of the virus to others. We are still finding that private insurers are engaging in discriminatory plan design by using drug formularies which discourage enrollment of people living with HIV and not covering an adequate range of drugs necessary to treat HIV. Without proper regulation and enforcement, this discrimination will persist. The Affordable Care Act includes important patient protection and non-discrimination provisions to ensure private insurers cover the drugs that people need without discouraging enrollment by any particular population. And yet, lack of enforcement to identify insurers who violate these important patient protections is pervasive. The HIV and Hepatitis Policy Institute recently filed discrimination complaints against 2 insurers, Medica and Harvard Pilgrim, for offering plans that discriminate against people living with HIV by not covering treatment regimens recommended in national guidelines, and in the case of Medica, by placing all HIV drugs, including generics, on the highest cost tier. Under ACA regulations, it is potentially discriminatory for an insurer not to follow widely accepted treatment guidelines or to place the majority of drugs to treat a particular condition in high-cost tiers. The availability of antiretroviral medications in multiple classes and single tablet regimens has improved the health of people living with HIV, and newer drugs have less toxicity, fewer side effects, and improve adherence. We urge the Secretary to take administrative action to ensure that the ACA's non-discrimination regulations are fully enforced. In the states where CCIIO has jurisdiction, it must investigate complaints and ensure plans are in compliance. In other states, CMS should update tools to empower states to review plans as they are filed annually to ensure that HIV drugs included in national treatment guidelines are covered and that HIV drugs are properly tiered. CMS regulations clarifying that these practices are presumptively discriminatory were first promulgated in 2016 and further updated in 2022. But the tools CMS provides to review the plans do not yet provide adequate protections to ensure that people with HIV are not discouraged from enrollment. Finally, the HHS Office of Civil Rights should be brought to the table in this process to further assess bias and discriminatory review with regard to insurance plans and their coverage of HIV drugs. Thank you.
Thank you. Please tell Carl Schmid we said hello as well. And next we have Dr. Sham Salade from CEO of Nexus Labs. Thank you.
I'm Sham Saladi. I'm the chief executive at Neelix Labs, a mid-sized reference laboratory and diagnostics company located in Chicago. At Neelix, we focus on increasing access to diagnostic testing by building solutions that bring tests to patients in the spaces where they're most comfortable. Yesterday, PACHA spoke a little bit about federal actions, or a lot about federal actions related to HIV and this endemic approach to STIs to improve access to care. We especially applaud recent rulemaking that requires insurers to cover the cost of PrEP without cost sharing to include critical and related services like diagnostic laboratory testing. Over the course of COVID-19, many Americans have become acquainted with COVID-19 testing at home. First through kits where folks collected their own sample at home and then mailed it to the lab, and later through test kits that provided a rapid antigen test result at home. Similarly, over the pandemic, virtual PrEP delivery models like Mr. and Q-Care grew significantly. These models allow patients to handle everything from their first statement of interest in PrEP to receiving prescription, accessing PrEP patient assistance programs, all from the comfort of their home or other non-clinical setting. Critically, patients do necessary lab testing from a home specimen collection kit that's mailed to their home, self-collect their samples, and then these samples are processed in a CLIA-certified, CAP-accredited, high-quality laboratory. Some estimates suggest that between 10 and 25% of all patients on PrEP receive their care through teleprep. Laboratory testing is a critical part. Laboratory testing of home collected specimens is a critical aspect of teleprep. Similarly, we know that home-collected STI testing increases access to care by allowing to test in the privacy of their own home while having the benefit of a healthcare provider upon receiving their test results. For example, we heard about the successful Take Me Home program yesterday. Unfortunately, accurate, safe, effective home use tests for STIs are not broadly available. And it's not because the technology doesn't exist. It's because our federal bureaucracy is moving too slowly. So I'll give you two examples now. So earlier this year, despite significant sized teleprep programs, FDA announced announced that home collected HIV tests with laboratory analysis could no longer be offered. This is a significant concern to all folks on teleprep because the lab testing is critical to prescription. Labs that offer these programs, like Neelix, are happy to work with FDA to obtain appropriate clearances. However, the process is extremely slow. Through the RADx program during COVID-19, FDA was able to work more quickly on topics of interest. I'd like to ask PACHA to request FDA and NIH open these channels, similar pathways for HIV and STI tests. Thank you so much.
Thank you. And just a reminder that folks have a week to submit written public comment for record. Please submit comments to PACHA at HHS.gov up to a week. And also today at 2:05 Central, we will have an opportunity for further engagement with our PACHA-to-the-People community engagement session. But thank you. Back to Chair McNeese.
Thank you, Caroline, and thank you for all of you who submitted public comment. That is a part of our record, and we do take those comments and consider those back in the work of subcommittee. So I appreciate you bringing forward, I think, some very critical issues for us to consider and move forward on. So thank you to everyone. We do have a bit of a break. We will start at 10 a.m. We will break now and we will start at 10 a.m. So see you back around the table. Thank you. So I wanted to offer opportunity for our very illustrious Kay Hayes to make some remarks before we get started on our panel.
Thank you, Madam Chair. This will just take a few minutes. I just wanted to say, as I was listening the past couple of days, that we are where we need to be at a time we need to be. And that is by no mistake. I just want to say that we are where we need to be when we need to be. And I'm reminded of two PACHA members that I want to bring into the space. And one is a former PACHA member, Bishop Yvette Flunder, right? And one of her songs, if you don't know who she is, she sang with Walter Hawkins. One of her songs is Thank You. And I encourage you to Google and look up the lyrics to Thank You. And you can also hear her sing it. And it reminds me of where we are and why we are here. The other person I want to bring into the space, and Jesse mentioned our former PACHA member, A. Cornelius Baker. And tomorrow is his memorial. But those of us that knew Cornelius well knew he was a historian. And I was having an EHE meeting, bringing our federal partners together to talking about our path forward. And that meeting was in September. And some of the federal partners and Rob and others were there. And Cornelius co-facilitated that meeting for me with Jeff Crowley. But Cornelius facilitates that meeting. And we had it at a space in DC, and Cornelius was telling us all about the building and the historical nature of the building. And did we know about it? So we had class, it was in session. But he challenged every federal partner in that room around ending the HIV epidemic. And he pushed and he pushed. And some folks got a little uncomfortable, but Cornelius pushed. And then he wrapped up and he got very emotional. And he said, as a Black gay man living with HIV, he thanked every one of us for the incredible work that we're doing because it mattered. And it mattered to his life. And then he turned and he said, okay, now wrap it up. I was like, how do I wrap it up after that? But I was just reminded of Cornelius and Bishop Flunder and so many of the former PACHA members. They would be so proud as I listened to all of the subcommittees, I listened to Wendy's update, that they would be so incredibly proud of the work that you guys are doing and pushing. So I would say in Cornelius' spirit, keep pushing. Keep pushing. And if folks get uncomfortable, it's okay. It's okay. We're adults. We should be able to take it. And that's something I've said before when some partners get uncomfortable. I'm like, it's okay. It is okay. We're grown. We're big adults. We should be able to take it. We should be able to take it. So I just want to say thank you. My word is gratitude. But thank you, Chairperson Marlene, for giving me that privilege to point.
Thank you, Kay, and what a beautiful segue. Yeah. So I certainly have been looking forward to this part of the meeting, like all parts of this meeting here in Alabama, really will be facilitated expertly by Rania Copeland and DeAndre Moore, and just looking forward to hearing and learning. So the floor is yours.
Thank you so much for starting us off. Thank you, Kay, for your words to keep going. Let's get uncomfortable. My name is Rania. I'm so excited to be able to co-moderate this panel. I am from Los Angeles, and to be moderating a panel called Barriers to Addressing the Intersection of HIV, Stigma, and Social Determinants of Health in the South means a lot to me. My family made their way to California from Philadelphia, and they made it to Philly. One side of my family, they can trace their roots to being runaway slaves. And the other side, they came up to the North as part of the Great Migration. And so really, for me, being here in the South, and I'm in the South often, I have the privilege of doing work and being in the South often, and then being here this week and seeing the amazing organizations and having the opportunity to literally sit at the feet of civil rights giants, to sit and be at the location with the Legacy Museum has meant the world to me. And I'm excited to bring the information, to bring the experience back to my 3 little boys. And I think that we've heard it enough that the way we're going to end the HIV epidemic is through the South.
And I think some of the disparities and the stigma that we really see in the South, we see across the country, but this is some of the rootedness of where it's at. And I think if we can figure out how to fix it here, we can fix it everywhere. And so I'm really excited to first, in this panel, delve into what are the disparities, what are the challenges? And then later today, we have an amazing panel of folks who are gonna talk about some of the solutions and the opportunities. But here today, it's what are the challenges? Let's really dig into it. So I'm excited. We have an amazing panel of experts who we're gonna be talking with, and I'm gonna hand it over to my co-moderator, DeAndre Moore.
Thank you, Rania. Appreciate that. And thank you to our chair and to our federal partners who are all here and for having us, and also to our amazing panelists who'll be speaking today. I'm going to open up with a few words and I ask for a little grace on time, please. As we're here in the South, I am a Texas native, Beaumont, Texas, to be exact, right on the border of Texas and Louisiana. Very close to Houston, but I definitely claim where I am from. Doing this work in the South is something that I've been doing for almost a decade, and specifically to Mississippi. I want to pay homage to someone that has been a colleague and a friend of mine who, unfortunately to our healthcare system, passed away this week, Zundra Batiste Sutton, who was a champion for U equals U and the lives of people living with HIV in the South, down in Jackson, Mississippi, all over Mississippi, Alabama, and Louisiana. We got the unfortunate news that she passed away, but I do want to call her name and honor her in this space because what happened could have absolutely been avoided. But again, healthcare access in the South, it's just, I'm a person who can attest to what it's like and the barriers that we face, also as a person living with HIV. And I'm going to be more vulnerable, I think, than I've ever been as someone living with HIV. About a month ago, I started experiencing a lot of pain in my head, and I started. It got to the point where I was so scared to go to sleep at night that I would set an alarm for every 2 hours so that my partner could wake up. And I had the alarms labeled: if I don't wake up, call 911. And I knew that I had to get to an ER. And so that's what I did when I got to Houston. I went to the emergency room, begged the doctors to just take a look at my head, give me a CAT scan, give me an MRI, give me something. And they denied me that at the emergency room because I did not have insurance. As an entrepreneur, if anybody knows what that's like, I have not had insurance for almost a year. And I've suffered for that in silence, and I've not been able to speak about that out loud because I've been so embarrassed to be someone who sits on such a prestige board of people with my colleagues who has been doing this work. How can you be someone who talks about these things, who talks about U equals U, and not have the healthcare or access to healthcare that you know that you need? They realized that I was a person living with HIV and told me that I had to go and see my healthcare provider in order to see if I could possibly get an MRI or scheduled one. And so I had to drive from Houston 90 miles to Beaumont just to get an appointment to try to get a CAT scan on my head, because at some point my healthcare provider even said that this could be an aneurysm. We don't know, but we should try to look at this. And so from there, had to make another appointment, and they told me I need to wait another week to try to get in to just get a look at my head when I know something is wrong on the inside. And so I just couldn't take it. So I went to another emergency room. And again, because I didn't have insurance and I needed this and I begged them to do this, the only option was to pay out of pocket $1,600 just to get them to take a look at my head. And I asked them, I said, well, what if I didn't have it? What if I'm a person who does not have that? They said, well, you got to get up out of here. We can't do anything for you, unfortunately. And so I did what I had to do. And the news that was returned wasn't the best, but I'm here today. And I'm thankful for this situation because it reminded me that because I did not have insurance and because I was afraid to speak up, I join you today as one of the 500,000 people in the US who are not virally suppressed. And I am still a strong supporter and believer that you does equal you. I'm thankful to say that now I am back on my medication. I'm in treatment. I'm in care. I've gotten the help that I needed, and to speak up for that. And it's important that we prioritize our health, regardless of how we feel or how we perceive that we should be. But those are some of the barriers that I face, even myself. And I realize that sometimes your privilege doesn't always save you. You have to speak up for yourself, and you have to advocate for yourself. So with that, I am excited to have this conversation about the barriers that we continue to see at the intersection of HIV, the stigma, and the determinations of health here in the South. And I want to open up the floor and get us started. And we are going to start with the Reverend Lauren Banks, who is joining us virtually today. Thank you.
Good morning, everyone. Thank you, DeAndre. Thank you. I am a native of Alabama, and I am very sad that I am not there. I've been sick this week, but I'm delighted to be with you all virtually. I'm going to share a couple of slides, just a couple, because I know I don't have too much time. All right. So I'm the executive director of the National HIV/AIDS Housing Coalition. We are a national organization that advocates for housing policies and resources to advance the health of people living with HIV. I want to show you the latest data that comes from CDC's Medical Monitoring Project. The Medical Monitoring Project is wonderful. If you don't know or haven't taken a look, when we're talking about systemic barriers to healthcare, the Medical Monitoring Project is amazing. So we see right here the correlation between adverse health outcomes and housing. And so the navy blue bars are those who have experienced unstable housing or homelessness, who are living with HIV, and then the light blue are those who did not experience. And we can see right here that there are disparities across the board of the care continuum. The most notable being those who have missed their ART dosage. 51% of those who experience housing instability in the past month missed at least one of their doses. And then 51% of those who are unstably housed are not virally suppressed, compared to 33%. So when we're talking about how we can support people's health, housing is absolutely the key. And as we say, housing is healthcare. And I'm frankly tired of hearing that it's a social determinant when really housing status is healthcare status. And we need to incorporate more how we're going to address housing in order to address the HIV epidemic. Speaking to the South, the national average of people living with HIV who experience unstable housing is about 18%. The NHOS goal is 11%. NAC just submitted our comments, and we think that goal should be 0%. But the current goal is 11%. Nationally, 18% of people living with HIV do not are unstably housed or homeless. You can see that Florida, of the states surveyed, not every state was surveyed, but of the states surveyed, Florida has 25.4% of people living with HIV, 25% are not stably housed. Mississippi, 24.8%, Georgia, 22.9%, and Virginia, if you count that as the South, 21%. Just to back up a little bit here, unstably housed means that you are having to live with someone because you don't have housing, which I would call that homeless, but that is considered unstably housed, as well as those who have been evicted and those who have had to move at least 2 times in the past year due to financial hardship. And then those who are homeless are those who live on the streets or in a shelter or in a car. Hopefully you've all seen this. This is Ryan White data from 2022 that shows Ryan White program clients with stable housing are virally 90.6% are virally suppressed. Temporary housing, those in short-term housing situations, 84%, and then those unstably housed, 78%. So again, these are people who are connected to care, who are in care, who probably get case management, and still one of the hugest factors is their housing status. I'm going to stop sharing my screen now. and talk a little bit about solutions and what we can do. And we know that this problem is more concentrated in the South because of lack of federal investments, because of lack of Medicaid expansion, all of the things that have been discussed for the past day and a half. But what can we do? We need to better fund the HOPWA program. The HOPWA program has continued to be drastically underfunded. Right now, it's at 500 million with an M, whereas the Ryan White program's over 2 billion with a B. We need Ryan White to be kept at very high levels, and we need to increase the size of that HOPWA funding. We need to better utilize Ryan White funding for housing in states that can do that. But I think the biggest thing that we can do is work with HIV organizations, CBOs on the ground to develop their own housing, to develop relationships with landlords, and to develop relationships with housing entities. For too long, they've been separate. But I want to call on those community-based organizations, FQHCs, all of us, to better reach out to housing partners to see what we can do to bridge the gap, to refer our clients into housing, to have at the ready who they should call, who the case managers are, where can they get a Section 8 voucher or put on the waiting list, where can they go for resources. We also need to pivot our focus a little bit more to working with HUD and to existing housing agencies and entities for testing initiatives and for linkage to care within the housing system. So there needs to be better overlap in those two things to address housing issues. I want to close with a personal story. NAC has an internship program of those living with HIV who have had housing instability or been homeless. One of our interns is Michelle Anderson from Memphis, Tennessee. Michelle was experiencing homelessness and started engaging in survival sex that shifted into being a career sex worker. She was living with HIV as a sex worker, and a sting operation was out, and she was charged with aggravated assault because she was living with HIV as a sex worker in Tennessee. And so she was made a felon, and she was also made a sex offender. Once she was a sex offender, she couldn't access many housing opportunities because there are churches or schools on every corner in Memphis, Tennessee. So Michelle worked tirelessly to try to find solutions, and she found the HOPWA program. And the HOPWA program, she says, saved her life because she was able to get stably housed. She was able to get healthy. And this past year, she worked with the ACLU to fight her felony conviction and her sex offender status. And she has been removed from the sex offender registry by working with the ACLU from aggravated assault because she was living with HIV. Not only that, this morning before joining this call, I was able to be a witness for her hearing virtually in Tennessee to change her name legally from Michael to Michelle, because Michelle is a transgender woman. And so at 39 years old, she finally gets to be called Michelle. And all of this is due to her hard work, unnecessarily hard work, but the way that our service providers, how housing and healthcare have worked together to support Michelle in her work and life. And I wanted the story to be on the register that Michelle Anderson is a true advocate in the South and the reason why we do this work. Thank you.
Thank you so much, Reverend Banks. And you did such an amazing job virtually, showing us, really highlighting the intersections of stigma, of disparities, of housing that are impacting people who are living with HIV, people who are impacted by HIV specifically in the South. So thank you so much for that amazing conversation. I'm sure we're gonna have lots of questions when we get there. Next, we are going to go to Ms. Linda Dixon. She is the Health Law Director for the Mississippi Center for Justice, and she's gonna talk to us a little bit more about Medicaid, the very exciting time topic that I think is ongoing, evergreen for us when it comes to HIV and healthcare access.
Thank you so much, and good morning, everyone. It's a pleasure to be here, and I really appreciate the invitation to join you to talk about access to healthcare and Medicaid expansion in particular. The Mississippi Center for Justice is a nonprofit public interest law firm. In addition to what I do in the health law division, we have a housing division, we have economic justice division, impact litigation, heirs property, let's see what I'm missing, education. So it's important for me to tell you that because we work from an intersectional approach. You know, people don't just come with one issue, they come with many. In the health law division, we focus on access to health care with an emphasis on children and families and HIV, stigma, and discrimination. So we're going to talk a little bit about access to health care, and it was great to hear all the discussion yesterday and today around Medicaid expansion and how many times that came up. It's important. Access to health care is a major barrier to success in fighting the HIV epidemic. Without health coverage, individuals are unable to access medical treatment to help improve their health care and minimize the spread of HIV. Medicaid is the largest source of coverage, health coverage for people with HIV. We have to pause there and think about what we can do to strengthen that and protect current programs. According to a 2020 report that I came across by the Georgetown Center for Children and Families nationally, 40% of people with HIV have Medicaid, while only 13% of the population overall is covered by Medicaid. Currently, let me pull this next slide up. This map is really indicative of the South and the issues that we have in the South. Look at the yellow, the gold on that map. All those states have not expanded Medicaid. So currently, there are 10 states that have not expanded Medicaid, most of which are Southern states. And what do Southern states have in comparison to the rest of the country? And as it relates to HIV, we have the highest rates of new diagnosis and a disproportionate impact on Black and Brown people, where we have a lot of population of those individuals. The decision not to expand Medicaid is harmful to the communities that we all serve and love and care about. 5% of people with HIV remain uninsured in states that have expanded Medicaid, compared to 19% uninsured among people with HIV in non-expansion states. And 48% of people with HIV are covered by Medicaid in states that have expanded Medicaid. Mississippi, where I live and care for people there, they look like other Southern states that haven't expanded. Our state leadership has adamantly opposed expanded Medicaid. Our hospital infrastructure, like I know in other states, struggling. Rural hospitals in Mississippi is struggling. 50%, half of rural hospitals in Mississippi are at risk of closing. If you have health insurance, you're still in trouble because you need to go to the closest hospital or emergency room to get care. So people have to drive 2 and 3 counties over to go to a medical facility. Now that's a life and death situation. In Mississippi, we have over 200,000 people who would gain coverage. I'm gonna say when the state expands, not if, but when. These are hardworking Mississippians who work in industries like childcare, contractors, barbers, people who are cashiers, people who serve us in restaurants. These were the same people who were deemed essential workers during the pandemic working on the front lines while we were at home, putting themselves at risk with no health insurance. 2 years ago, Mississippi passed a postpartum bill for women from 60 days to 12 months. And we were one of the last states to do it. Like we were one of the last. So now it's 12 months, which is great. But what happens after 12 months? It's taken away from you. So the health care that you've relied on for a year is gone. And that's really scary to think about. Let's talk a little bit about money in the economy, because people understand that, right? Medicaid expansion could really boost economies by creating jobs, reducing uncompensated care costs, and increasing access to preventive care. Ultimately, what does this do? Fosters a healthier, more productive workforce. So people can go to work, right? In fact, Mississippi leads the nation in medical debt and medical bankruptcies. Working families across Mississippi are struggling to make ends meet, like in other states and everywhere else across the country. And they're going into enormous debt. We just heard you sharing your personal story, thank you, of what you have to do to see a doctor. The first thing they ask is, where's your health insurance? Are you turned away? So a lot of people don't even seek care because they know they're going to be turned away. That's awful. So I shared about the hospitals and the risk of closure. So uninsured individuals often seek care, of course, when emergencies arise. And this uncompensated care costs continue to strain hospitals as they struggle to stay afloat. Expanding coverage would increase access to preventive care and reduce the burden of the uncompensated care on our healthcare systems. Mississippi and the 9 other states suffer losses of millions of dollars by not expanding Medicaid. We know that no state has ever not received their match. No state. The money has been matched. So to say, well, we don't know what's going to happen. Come on now. We know. So 1 minute. Oh. So I'm so passionate about this, I could talk about this forever. So thank you. So for consideration, I'd like to offer just a few factors. One, the racial inequities that plays a role in this are just completely staggering. We know, and I'll just quote Mississippi, Black Americans bear a disproportionate burden of HIV. And in a state like Mississippi, we have 76 to 77% of new diagnoses are of African Americans. And lastly, I want to point out for consideration, rural Mississippi and other rural areas in the country, in particular in the South. In Mississippi, about 52% of Mississippians live in rural areas of the state. Lack of transportation is a huge issue. There is no designated public transportation system, and we expect people to get from one place to the other. How, right? Rural Mississippi is defined as those areas outside of the city of Jackson, our capital city, and the Memphis metro area, which is bordering Mississippi, Tennessee, has long suffered from a lack of HIV services due to many factors. And one factor is the lack of consideration that a majority of persons living with HIV live outside the metro area. It's almost 70%. So we have to think about how we can strengthen hospital infrastructure, how we can make sure that people have access to the health care they need. And this is one of the ways to do that. Medicaid expansion is a significant piece of many to ending the HIV epidemic, making sure people have health coverage. It helps to expand HIV testing. It leads to reduction in new cases and the mortality rate. And I'll close by saying stigma. I always want to mention stigma because we know it's the core of all the issues and the root cause and driving force of discrimination. Thank you.
Thank you so much, Ms. Linda. And again, we'll take all questions and comments as we get to the end of this. We want to make sure we get all of our speakers the opportunity to speak. And so I'm going to turn it over to Ms. Ellen Eaton, Associate Professor of Medicine at the Division of Infectious Disease, Department of Medicine, Hersink School of Medicine, University of Alabama at Birmingham. Ms. Ellen.
Thank you so much. And thank you to those speakers who came before me who so nicely set the stage. We're going to discuss barriers to addressing substance use and HIV in Alabama. As we have discussed, they are intricately intertwined. This is a picture of Dothan, Alabama, my hometown, which is just south of here. And the rural poverty, I cannot summarize in a photo, but just want to share some disclosures here. Okay. Oops. Syndemic disease. So I'm going to go through several barriers to care. I do have an outpatient clinic that integrates substance use and HIV treatment in a Ryan White setting. But what I want to remind the group is that Ryan White clinics actually represent higher access in our community than is available to those who do not have HIV, but are at risk for HIV. So I want to summarize what the community experience is with healthcare, and then I'll close with an example in a Ryan White clinic. But again, many people living vulnerable to HIV have minimal access relative to their neighbors and community members who are living with HIV. So this is some of our work from the hospital lens, the acute care lens. In Alabama, hospitals are our safety nets. Many people do not have routine outpatient care preventive services. Syndemic disease is a barrier to care. It's a barrier for individuals who are living with substance use and hepatitis C who do not have the bandwidth to take on HIV prevention simply because of competing demands. It's also a barrier in communities who are struggling with substance use and other chronic diseases in their community and do not have the bandwidth, resources, infrastructure to then take on HIV. And I'm showing you some maps here of the state of Alabama. This is some hotspot analysis we've done of Medicaid enrollees in our state, a biased sample. As we've discussed, we do not have Medicaid expansion, but from this database, you can see overdose and hepatitis C are high, disproportionately concentrated in North and Central Alabama. You can see Jefferson County, North Central Alabama, and moving up into the foothills of Appalachia, which we know has been burdened by opioid and other substance use, and in conjunction, hepatitis C, a syndemic infection. What you'll see to the far right is HIV. We know HIV is disproportionately burdening the Black Belt. We heard about that yesterday. You can see it in South Alabama. In an ideal world, you would look at these maps and say, these North Alabama counties are at risk for HIV. There's not a huge burden yet, but hey, let's get our prevention services. Let's start testing. Let's ramp all this up in North and Central Alabama. They are highly vulnerable, but you can imagine at a community level, an under-resourced community who has limited public health infrastructure, lack of Medicaid expansion, these syndemic diseases can just overwhelm communities, making prevention move to the back burner. Next, I want to talk about access, which you all have nicely laid the foundation for. This map summarizes some of our experience at UAB, again, Birmingham, Jefferson County, county seat of Alabama. What you'll see in these yellow regions are the residences of my patients who I see in Birmingham in the hospital for complications of injection drug use. These are life-threatening infections in young people, 30, 40 years old, heart infections, bone and joint infections. Once we treat their infections and hopefully start treating their substance use, which put them at risk for endocarditis and HIV, hepatitis C, we send them out to their rural communities in yellow, which are across the state. I did not show Tennessee, Georgia, Florida, Mississippi, which we also send them home to. But if you can see, the red pen demonstrates where there are substance use treatment providers who are taking new patients. The red dots are taking new patients for opioid use disorder, according to a SAMHSA database a couple of years ago. So huge disconnect. I can do my best in the hospital to treat the acute infection, but when it comes to continuity of care, community-based care, HIV prevention, there are a huge lack of services. Lack of integration. We have looked at AIDS View, which is a resource many of you are familiar with, lists of harm reduction sites, organizations that self-identify as providing harm reduction in the state. We have identified 98 of them. And we did a standardized survey where we called them, or several of our wonderful medical students and staff called them and said, harm reduction, how about Hep C testing? What about treatment? How about substance use treatment? How about naloxone or Narcan? How about fentanyl test strips? What other resources? And what you can see here on the right is that most do not provide comprehensive harm reduction. At the top, you can see on the far right, about 77% provide HIV testing, 68% provide Hep C testing, another 66% provide Hep C treatment. But at the bottom, you can see only 18% provide Narcan. Only 23% provide medications for opioid use disorder. Only 4% provide fentanyl test strips. So you can see these are not integrated or comprehensive resources. And I'm going to show you where they are located on the map so you can again visualize the disconnect for our patients. Rural geography, another barrier. We've heard about this. We have silos of care. We've heard about the need for nurses, nurse practitioners, advanced practice providers. That is who is serving these rural communities in yellow where I'm sending my patients to get care. These are our neighbors, our community members. They are doing great work, but they are doing great work with very few resources and support and even training gaps around mental health, substance use services. You can see that map again on the left. And then in the center image is where my patients drive. They live in these little green dots, and you can see the blue dots are the harm reduction sites. And I've tried to map it out for you on the far right so that you can see if John Smith goes home to his rural county in green where he lives, and he then wants to drive to get Narcan one place in blue, he wants to drive to get fentanyl test strips, he wants to drive to get PrEP or HIV or Hep C testing or screening, you can see that he has to travel an average of 12 minutes, around 12 miles to get each of these services, right? Because they're not integrated. And as we heard, we do not have public health transit. So you can imagine someone doesn't have a vehicle or they don't have gas. And we're telling them that to access these comprehensive HIV prevention, syndemic treatment, harm reduction, medications for substance use, we're telling them they have to drive all over the state, right, to get these services. And again, this is a group that is super sick. They were just in the hospital. This is not that person who is early experimenting with substance use, maybe has just developed a risk factor, become vulnerable to something in the recent past. So I'm giving you the most sick of our community members and showing you the barriers to access and how rural geography affects them. But remember, there's a spectrum of patients here. And then lastly, I was not asked to speak in the solutions group, and I apologize. I did give a solution a little early. But I did want to just remind the group that integration is really key. And when talking about Ryan White clinics and many of my colleagues, age service organizations, Ryan White partners in the room, I see you. This is the model that we have at the 1917 clinic. This is me and my team. We just celebrated our 5-year anniversary. You can see the cake. So this is an office-based addiction treatment integrated within a Ryan White clinic. We are the only one I'm aware of in the state of Alabama, and also many of our neighboring states. I do not think have a similar model. We have a peer recovery coach with lived experience. We have myself and another physician colleague, social worker, nurse. Pharmacy champion is essential for those prior authorizations, all the things, all the barriers. Yes. So integrating is key. You can imagine this model with nurses. This does not require an MD. A nurse champion, a nurse practitioner can do this model, can and should in our Ryan White clinics. Talk to your APPs. This is how we meet people wherever they are. This is how we integrate PrEP services while giving people their buprenorphine. Integration is the key. So with that, addiction medicine is medicine. We should not silo it. We have to train the workforce, and we have to integrate services to meet people where they are. So thank you so much for your time.
Baby, we got the fire panel over here, okay? You guys are on time and everything. So thank you so much, Dr. Eaton. That was fantastic. Next, we're going to go to Tavel Kindle. He is the Director of HIV Prevention and Treatment at St. Thomas Community Health Center with the Louisiana Commission on HIV and Hepatitis Education, Prevention, and Treatment. And Dr. Kindle is going to talk a little bit about the actual patient experience when it comes to barriers when it comes to HIV.
So much. Awesome. Thank you so much. I'm really excited to be here with y'all. I don't know how I got on PACHA's radar, but I'm really excited. I was introduced as Dr. Kendall, but I think it's important for everyone to know that I am a family nurse practitioner. I don't want to get sued by using the title doctor in a public setting. So I just want to make sure, because that is a thing, believe it or not.
PhD though.
It doesn't matter. I'm still a nurse and I don't want to get sued because it's been done. So Let's make sure we know. I'm a nurse practitioner. So I want to talk to you guys about kind of what's happening in Louisiana, which is really interesting as it relates to what's happening in the South in general. I was just at a Ryan White clinical update. And so one of the learning points that they highlighted while we were there was talking about, how, or why we are seeing new transmissions. And so you can see that I have provided it. So pretty much people that do not know that they have HIV, or they're not receiving regular care. And then when you look to the right, you'll see what I've provided from the Louisiana Office of Public Health as it relates to what's happening regarding the HIV epidemic in the state of Louisiana. So roughly 22,000 people have been identified as living with HIV in our state. About 15,000 of those are virally suppressed. So that leaves another 7,000 that are currently not virally suppressed. Per the definition of being in care, you can see 88% of those people are actually virally suppressed. So when put another way, at any time when someone is not virally suppressed, we know that transmission is more likely. And so when you have 7,000 or so people that are in the state of Louisiana that are not virally suppressed, it makes sense why we continue to see new cases. You may be able to see it's kind of small, but this is a graphic that was also provided from the Office of Public Health that roughly, I think it was 857, so maybe almost 900 newly diagnosed individuals in the state of Louisiana in 2022. You can see about 75% of those were men, but then there's a maybe 23 to 24% were female. And when you look at it a little bit more closely, of that number of females, over 80% of those women were Black or African American. And for the first time in 2022, Black women were number 2 as it relates to new HIV cases. And so, part of what we've been doing with the Louisiana Commission is really highlighting that as an issue and making sure that we are getting into spaces and places and making sure that we're working with advocacy champions in our state to elevate what's happening with Black women in our state and trying to make sure that they are aware of the resources that are available to them for both prevention and treatment. And I know you all are aware that, Black women in some situations are unaware that PrEP is even for them. So I think it's important for us to continue to work in that space. When you look a little bit more closely at what I provided for you in this schematic, you'll see that we have challenges as it relates to HIV in the rural parts of the state. A lot of the resources will go to New Orleans and Baton Rouge because that's usually the areas where we see more incidents. But there's someone living with HIV in every parish in the state, and it also means that there's likely someone living with HIV in every parish in that state who do not know that they actually have HIV. And we do have challenges, just like colleagues have said, in terms of access to care. Advanced practice providers have not been provided the opportunity to practice to the full extent of education and training without collaboration in our state. And you'll see that, unfortunately, across the entire place where the HIV epidemic is happening, advanced practice providers do not have those privileges to some degree. So that certainly is an area where I do believe that nurses can be most impactful. I'll talk a little bit about why later as we go through here. So, but this was just making sure that we all understand. I'm not putting this up here to admire the problem, but I think it's just important for us to know that this is what's happening in our state. So, and again, this is another list. Again, I'm not trying to admire the problem, but I mean, I know you all are familiar with all of these things. And these are the things that I do see they play out every day, in clinic when I'm taking care of patients. So I'm not going to go through all of these, but if you just take the top line of racism, discrimination, and HIV stigma, I'll share with you just kind of what this looks like. So we had a gentleman who was basically at home on the couch dying, and that's basically what he had decided to do. He just wasn't going to access care or do anything because he had negative experiences with other providers in the community. The providers that he has that has provided care for him all the time that he's been living with HIV, he shared with me, have been white, and they mistreated him, and all of the social structures and things that he had to try to navigate through, he was always mistreated. He just got really sick and tired of that. Also not wanting to deal with, the stigma associated with living with HIV and how he would be judged and treated. So he just decided he was going to die. And his daughter, fortunately, knew one of our board members of our clinic and told her, "Hey, look, have you met Deval Kendall. Do you know about him? I think, you know, you really should try to get your dad to come in to see him because it could very well be that, you know, he may have a better experience with Deval Kendall. And so he did get a chance to come in to see me. This gentleman now is thriving, but it's really interesting how the things that he shared with me, all of the things that he experienced leading up to the point to where he is now, and for him to be flourishing is just really exciting for me, and for me to be able to provide an opportunity for people who may have had those experiences in the past. It just really brings me a lot of joy to be able to do this work. When you look at, thank you. When you look at the bottom where it says knowledge deficiencies, biases, and stigma among healthcare providers regarding HIV prevention and treatment services. So put another way, we do have a lot of providers in our communities in Louisiana who are not offering PrEP. They are unwilling to prescribe PrEP. They don't want to learn about it, and they'll tell patients all the time, I don't do that. You don't need that. Why are you asking me for that? And these kinds of things play out in clinic, because when they finally come to see me, I'll ask them, well, who is your primary care provider? And would you ask them about PrEP? And they share all of this stuff with me. So they are really telling on what's really happening in our community as relates to healthcare. And I know sometimes we'll say things like, well, you know, people want to be seen by people who look like us or other Black providers. But I can tell you that, you know, there are some areas of concern there as well, because there are a lot of Black prescribers that are not necessarily wanting to learn how to prescribe PrEP and unwilling to offer PrEP in situations. And so I've had a number of patients who come to me for PrEP, and they've had providers who actually look like them who wouldn't give it to them. So we do have a lot of work to do there as well. And then finally, with medical mistrust, I mean, that is a thing. I have a lady right now who's she takes her HIV medication the way she wants to take it, and that's not every day. And she's been reading everything online as it talks about her kidneys and her liver and all the different things, and so we're having to try to unpack some of that stuff with her and help her to understand, look, baby, that's why you're here with me, so I can help and monitor all of that, so you don't have to worry about all of that. But helping her to have a relationship with me where she trusts me is where we are right now. So when we talk about the barriers in care in terms of what I'm experiencing clinically, because I think that's what I was asked to talk about, certainly in the Ryan White setting, I'm very fortunate. I have a Ryan White funded clinic, and I have case managers and social workers and all of the team members that are really, really helping me to make sure that we address all the things that my colleagues have mentioned, but it is certainly a challenge. But for me, you know, my thoughts are surrounding, you know, what am I going to do in terms of their care? So I have listed here, patients have been eager to start ART, regardless if they are newly diagnosed or they're returning to care. They really want to get started. But the question is, what do you start them on? And I provided the guidance as it relates to, the integrated-based regimens as first line, and other options that are there, especially in the setting if they may have had cabotegravir long-acting for prevention, what we should do. But I'm fortunate in Louisiana, we're Medicaid expanded, and Medicaid covers the cost of antiretroviral therapy for both prevention as well as treatment. So I, as well as my colleagues in Louisiana, we can get access to medications for those that are most vulnerable. But, my questioning and the questions of my colleagues are, okay, so we've got to take into consideration all of this new emerging evidence now as it relates to integrates and TAP and weight gain, or lipid changes, or TDF and, kidney, toxicity, and all these different things. And so if you have someone who's newly diagnosed and they're already obese, where am I going? If the guidelines say start this, but then I have this obesity to deal with, and now I'm going to put them on something that's going to make them even larger. Like, what exactly does that look like, and how? It's exciting to have the options, but it's a lot to think about, because you want to make sure that people are set up for future success, right? Rapid start, as well as rapid restart. Those are concerns that we don't always have the, profile or information. The electronic health records sometimes can be helpful, because you may have access to, some electronic record if you have maybe Epic or something like that, but you don't always have access to that, and they may not be able to always tell you, oh, I was taking the red, white, and blue thing, or I was doing this, so you're having to kind of piece all this stuff together and try to make safe decisions as best you can. And then I'll just talk a little bit about the prior authorization process. If there's a way for me to jump off a bridge, it's probably what's going to happen. It's going to probably be related to the prior authorization. But it is really, really challenging trying to make sure that people have the medications that they need and the time that it takes to go through that. It takes you away from patient care and the things that are absolutely needed. And then just finally with treatment non-adherence. So there is some emerging evidence as it relates to the impact of the long-acting injectables are having on people who will ordinarily not be virally suppressed because they have challenges for whatever reason in taking oral medications. And so it's really exciting to be able to do some of these things. I do have several patients who are now for the first time undetectable with the off-label use of long-acting injectable. And so, moving forward, I'm excited that see any new emerging evidence as it relates to that. Okay, I got to wrap up. Okay, I'm sorry. So best practices as it relates to retention and care. So flexible access certainly is something that is necessary, making sure that people have, access. So I try to do same day, next day, as well as I'm not doing any late hours or weekends because I do not life, but but I do offer a lot of bit of flexibility. I'll just, if you want something solved though, and if there's one thing I want to leave today with PACHA is that if you want some way to truly end the HIV epidemic, you really need to get the nurses involved and really get the nurses moving along. Nursing is the most trusted profession, it's the largest healthcare profession. If you want the problem solved, get the nurses to do it. The patient-provider relationship is critical, and I'm grounded in nursing theory as it relates to that and how I work to take care of patients, helping them to achieve goals and making sure that I'm addressing all the things in their environment. These old nursing theorists talked about the environment, but that's just a buzzword for what we now call the social determinants of health. So none of this stuff is really new, but I think it's important for you to know that what nurses do are truly grounded in theory and grounded in science. And just leveraging technology and being really creative in creating roles that provide opportunities for patient engagement and patient relationships, because that's truly the way to keep people in care and not just provide it some data to the right as it relates to what's happening in my clinic. It's a relatively small clinic in terms of when you look at some of the other clinics, they have 4 and 5 and 800,000 patients, but my clinic is doing really well. But it's because we really, really do a lot of work in terms of the patient-provider relationship and our relationships among the patients. So
Thank you so much, Mr.
Thank you.
And I just want to check. I just want to remind everyone that that this presentation has been given to all of our members. Correct? We do have access to these presentations. Cool. And also to your point, when you asked about, you're not sure how you ended up on this radar, I just want to encourage you and remind you that, because of you, someone decided to live and then decided to get off of that couch. And so don't ever question why you are where you are. You're here because it's where you're supposed to be. So
Appreciate it. Thank you.
Next up, I want to introduce our next speaker who is joining us virtually, the co-executive director of Positive Women's Network USA, Ms. Marnina Miller. Marnina, you have the floor.
Thank you so much, DeAndre, for your vulnerability and your transparency this morning. That really meant a lot to me as a person living with HIV. So I definitely empathize and sympathize with you. And I appreciate you being so honest with us. I want to thank PACHA for this invite, and what an amazing presentations we have heard thus far. I'm really saddened that I couldn't be there with you all in person. I attended a gala yesterday where I received an award from the Normal Anomaly, which is a local Black queer-led organization here in Houston, Texas. And so I definitely wanted to support them. My name is Marnina Miller, and I humbly serve as the co-executive director of Positive Women's Network USA. As someone raised in Michigan, I proudly still call Houston, Texas home. My family roots are spread all across rural Arkansas, and so the South has had my heart in more ways than one. But today I want to talk about expanding and modernizing the Ryan White HIV/AIDS program and addressing health disparities for women in the Deep South. If you haven't heard of Positive Women's Network before, we are a national organization, membership body of women living with HIV that really advocate for our lives through policy advocacy. So one of my mentors has always told me that data without context can be harmful. So I wanted to revisit a critical but often overlooked history, the experience of women living with HIV. From the epidemic's onset, women were marginalized. Early HIV definitions didn't even include us. in these symptoms, and it left many of us undiagnosed and without care. And it took over a decade of relentless activism to demand recognition of our unique needs. Despite progress, systematic barriers, particularly here in the South, they continue to hinder our quality of life and our quality of access to HIV care, especially for Black and transgender women. This history is a stark reminder of our ongoing need to modernize and also prioritize an equitable response for the HIV epidemic. And so, as you all can see from the screen, in the early days of the HIV epidemic, women were erased from the narrative and from the medical definition of HIV, and it really excluded many of our symptoms that we were facing early on. However, even today, we still see erasure in our healthcare system. The exclusion of women, especially cisgender and trans women living with HIV, from clinical trials since the early on days of the HIV epidemic in 1983 still had us overlooked in research. Still to this day, we're not allowed to take certain medications due to the lack of research that has been done in not only cisgender women, but also women of trans experience too. And so to address these ongoing disparities in HIV outcomes, we have been demanding inclusive trials that prioritize the lived realities of all women. Inclusive research is not just optional, it is essential for achieving healthcare access and ensuring that no one is left behind. And as you can see from this slide, it wasn't until 1993 that women were included in the definition of AIDS. And before this change, folks really failed to account for our conditions. Advocates relentlessly pushed for recognition, and it wasn't until 1995 where we see vertical transmission guidelines updated to also make sure that folks who could bear children had access to medication so that their children wouldn't be able to contract HIV. This milestone really underscored the importance of access to life-saving treatments and the potential of science to empower families, proving that a diagnosis doesn't mean that the end of a possibility or parenthood. And even though this took place in 1995, I know that we all know dandelions, lifetime survivors, or folks who acquired HIV at birth. We know folks that are older than 29 years old that are living with HIV because of this lack of inclusion from the FDA. And then also by 2000, because of this lack of inclusion, we now see that Black women, Indigenous women, and people of color that identify as women are bearing the largest burden of the HIV epidemic, particularly in the South, a region already deeply impacted by system inequities. We face intersectional barriers like poverty, lack of access to healthcare, stigma, racial discrimination. All of these make us more vulnerable to an HIV epidemic. So here's the current state of play in the United States, especially in the Deep South when we're talking about women living with HIV. In the South, women currently represent 24% of all new HIV diagnoses, with Black women bearing the greatest burden of that. These disparities are fueled by the things I talked about earlier: racism, stigma, discrimination. And the Ryan White Care Act has been a lifeline for so many of us, but it is not yet tailored to meet the unique needs of women living with HIV, especially in the Southern region. Women in the South face layered challenges: lack of access to gender responsive care, reproductive health care services are limited or none, and social inequities like housing and transportation make it even harder to access care. But as women living with HIV in the South, we do not take these disparities laying down. We have been fighting back to ensure our survival because we know that no one is coming to save women living with HIV in the South. We have to save ourselves. But here's where I would like for us to talk about some possible recommendations that I would love for PACHA to think about. I would love for PACHA to advise the Secretary of Health and Human Services to work with HRSA and HAB to address health disparities for fully integrated, comprehensive sexual and reproductive health care for people of all genders throughout the Ryan White program, and adopt a minimum standard of care for cis and trans women living with HIV. And how would you all do this? How could they possibly do this? We are looking at 3 different buckets that we're really thinking about. Mandating gender responsive care. When we talk about the fact that women of trans experience haven't been included in research trials, it's because they haven't. We haven't seen them fully integrated in research trials, including all of their lived experience around gender affirming care that they have. We haven't seen an expand of women-centered services. So we really need to tailor our Ryan White care services to make sure that folks have access to peer-led networks for women living with HIV, also reproductive health care throughout the Ryan White care program, and also making sure that there are daycare services available, because folks who assigned female at birth, women, and also women of trans experience have children. So we need to make sure that we're caring for the entire family. Also, the last point I'll make is integrate HIV and reproductive health care. As someone who doesn't have any children and is looking to one day be a mom, I know that I would have to seek outside of my HIV care to get real reproductive health care. Currently in Texas, we know that we have a lack of access to reproductive care. I currently sit in a state where we have the highest infant mortality rate, and the worst maternal health rates for Black women are strategically in Texas. And so as someone who's also impacted by all of these things, these are my policy recommendations for PACHA to take back to the Secretary of Health and Human Services. And with that, I'll stop sharing screens. That's it for me, y'all. Thank y'all so much.
Marnina, thank you so much. That was fantastic. And to close out our panel, we have Judith Montenegro, the Program Director of Latinos in the South from the Latino Commission on AIDS.
Good morning, y'all. I'm Judith Montenegro, and when I talk about the South, I'm going to talk specifically about these states. No offense to the other southernish states, except for Delaware, who I always give a side eye to. I'll also share that the South is the most diverse region in the country. It is queerer, it is Blacker, it is more Latino or more brown than any other region in the US. And so when we talk about these things, it's important to note the diversity of the region. I'll also share that Latinx communities have always existed in the Southeast through borders that crossed us, forced migration, immigration, and the fact that many folks are native-born Southerners too. The first Spanish language newspaper in the US was called El Mississippi and was published in New Orleans, Louisiana in 1808, making it the earliest known Spanish language newspaper in the country. Hondurans at one time where the largest settlement of Hondurans were in New Orleans, only surpassed by the Honduran cities of San Pedro Sula and Tegucigalpa. I also want to name Lucero Sitz into this space, who for a long time worked here in Montgomery, Alabama, doing Latino outreach as a coordinator around HIV. She is now retired, so she didn't get an opportunity to be in the space, right? Oh, I have to control it. Okay, so if we exclude Texas and Florida, and I'm gonna do that a few times, sorry. We have a longer standing history of immigration and migration of Latinx individuals in some of these other Southern states. So if we look at states like Georgia and North Carolina that have a growing Latinx population at 10.5%, 10.7%, right? We see that, we're growing. But then if we look at the percentage of growth that has occurred, states like Tennessee and Louisiana saw a larger percentage increase over the past 10 years, right? At 67.5% and 65.2%. But then if we look at what happened from 2000 to 2010, which was when my program was founded in this response, we see that the percentage growth in Alabama was 144.8%, in Georgia, 96.1%, In Mississippi, 105.9%. In North Carolina, 111%. In South Carolina, 147.9%, and Tennessee, 134.2%. And I only don't mention Louisiana because it didn't get us close to 100, but I mean, it's a respectable 78%, right? And this growth has really benefited states where, for example, North Carolina survived the housing crisis in the 2000s because of the growth of this population and led to some of this continued development that happened in entrepreneurship of new migrants coming to the state. Growth in populations have benefited rural areas, revitalizing many southern towns where folks had already left. Rural towns saw growth of industries like poultry plants, pork plants, farming, manufacturing, and many of these towns are sourced and run by Latinx communities. We also see that southern states have grown in congressional seats and in state budgets because of this growth, and there's some irony there, right? We also see that the climate crisis has also led to forced migration to the South and from the global South, where over 120,000 Puerto Ricans moved to Florida after the hurricane and settled in Orlando, and many settled in Orlando, not all. Southern states are experiencing a higher intensity and frequency of natural disasters, leading to a need for increased funding for disaster relief efforts and funding for the coordination and response for recovery. In my home state of North Carolina, Western North Carolina experienced a severe damage for rural and mountain communities where they were left without water, electricity, communication, roads were completely destroyed. And so it was very difficult to get resources in and out. And it also prevented individuals from accessing some of the vital healthcare services that they needed, including their medications. So now this environmental justice need is also needing to be part of our HIV movement, right? Where we have to ensure that communities are being restored, that are being impacted, and that we're able to safeguard the resources that we're developing in these rural areas, in these mountainous areas, in these coastal areas. And we have to be part of that preparation too. And so increasing funding and support for staffing is also needed because health departments are having to respond as well. When we think about social determinants of health, geography absolutely plays a role, and it's vital for resources like healthcare. And I could talk about them, right? I could talk about how there are a shortage of bilingual providers in the South and a shortage of nurses, right? I could also talk about how many of our folks live in food swamps and food deserts, right? And by having good nutrition is also part of that well-being of people living with HIV and folks who are impacted, or housing, but Lauren did an amazing job. And transportation, right? Many of you have experienced the difficulty of just accessing an Uber here in Montgomery and may have paid close to $200 to get here from the airport. And so when we think about what happens to our patients and clients who come in for services, we understand that these are all things that are impact how folks access services. But we also have to realize that the socioeconomic and political conditions that we are creating, right? That criminalization shows up in communities in different ways. That I could also talk about how immigration rates impact communities, right? And how they show up in different ways, including at deep levels that we often don't think about, like preterm births and lower birth weights in communities where after an immigration rate occurs, and it is regardless of the individual's immigration status. The lack of, here's an image of the uninsured rate of Hispanic and Latinos, ages 0 to 64, and we can see the concentration in the Southeast. The lack of Medicaid expansion has contributed to the higher than average uninsured rates for a lot of Latinx communities, because many of us work in industries that don't offer employer-based health insurance, right? In construction, in hospitality, in agriculture, maintenance work, as well as entrepreneurship, right? Medicaid is transformative for states and providing some of this equitable access to healthcare. Of the close to 600,000 individuals enrolled in North Carolina's expanded Medicaid, which celebrated its 1-year anniversary on World AIDS Day, 217,000 folks enrolled are from rural counties. However, we also know that there are a lot of southern states that still staunchly resist Medicaid. And I know Mississippi's next. So we have to think of new strategies, asking ourselves who can respond to these needs and to the incredible advances that are happening around HIV prevention and treatment. And we believe that pharmacists can also play a vital role, right? In expanding the role of prevention and making sure that folks have access to these services. But we need pharmacists to be labeled as providers. Clinics and health departments in the South do work traditional 9 to 5 hours because life, right? And many don't open on the weekend where working people need to access some of these services. I once visited a health department in Adrian, Georgia, that was open every Wednesday and the third Thursday of the month. And on the third Thursday of the month, it was open from 8 to 4. And so you could say, well, the health department in Swainsboro or Emmanuel County is only 20 minutes away, but we've also seen that transportation is non-existent. Oh, how do I click? Oh.
Move it.
Okay. And so finally, I'll say that we are younger. The median age of Latinx communities across the South, you could see, are probably 10 years younger. And so even though we make up an estimated 19% of people in the South, but account for a greater share of new diagnosis at 42%, and estimated people living with HIV in the South are 34% in the region, when we think about some of these trends that are happening, we note that the age group most impacted in diagnosis are ages 25 to 34 across the country, right? But here's how old we are in the South. And like, let's exclude Florida, right? Just for a second. But we need to continue to invest, and we need to make sure that our investments that we're making and the interventions keep this in mind, right? Because the interventions that maybe work in some of the states where the median age for Latinos is a little older, right? That's not the case in the South. And so we need to continue to invest in community-based organizations, because that's at the level where we know that they serve as organizational homes, political homes, and where they are receiving trusted sources of information. They can address isolation, they combat stigma, right? And so we need to ensure that we're still funding community-based organizations throughout all of this so that they can help respond in HIV as well.
Thank you. Thank you. Round of applause. I think now this check. Okay, this is the part where we're going to open up for Q&A really quickly. I also want to be really mindful of time. I can't speak for everybody else, but when I say my stomach is touching my back, I am hungry. So we want to make sure that we keep you guys on a time strain, and we'll take time on that. Before we go around the room and ask questions, Ms. Linda, you talked about Medicaid expansion and Medicare and all those things. Last week, I had the privilege to attend the White House symposium on enhancing the lives of people living with HIV, thanks to the UNEP director, Francisco, and thank you for that. At that symposium, the previous UNEP director, Harold Phillips, brought to my attention and asked for me to bring up something that I think will be a solution to help with Medicaid and Medicare expansion, is that for PACHA to make this recommendation. And so if I may, on World AIDS Day, President Biden said that CMS would redo the HIV bulletin before he leaves office. This will detail and encourage Medicaid programs to work better for people living with HIV. And we think it's important that when this was first done in 2016, it did not include the U=U language and really push viral suppression. So we want to encourage HHS to fulfill the president's goal and to include U=U language and actions that will increase viral suppression rates in the United States. We have almost less than 30 days left to make this happen, and it's important for us to ensure that we can do our part. And so I want to make sure that that goes on record for us to get that to the secretary's desk at some point. So thank you. And now we can turn it over for questions.
Any questions for our panel? Let's go to Carol. Are you gonna talk about nursing, Carol?
Yes. Yes.
Thank you to that panel. This panel was amazing. It really did a whole picture. So thank you all. And I particularly want to thank you for showing those maps that were stunning. The maps about non-Medicaid expansion. And when I do my presentations, I use 3 maps: non-Medicaid expansion, HIV, and full practice authority for nurses. And full practice authority for nurses is something that's decided at the state level. But I look to the HIV criminalization modernization movement, because again, HIV criminalization statutes and laws are at the state level, but yet there's been a national movement to bring awareness and address that. And I would like to suggest that PACHA, and I am we, or I am us, but that we think about how do we raise that issue of full practice authority, because we certainly not only heard it, but I was very, it was great that there were so many other people that supported that in the audience, and everybody loves nurses, we know that. But how do we move that love to action? And so I would like to put forward that just like learning from the HIV criminalization modernization movement, even though it's a state-based activity, and just like Medicaid expansion is a state-based activity, having a national voice or a national presence around that, a national awareness around that, could also be translated to full practice authority for nurse practitioners. And that has a lot of ramifications. It's not only about nurse practitioners, advanced practice nurses who can go out into under-resourced communities. It's also about graduates of master's and doctorate programs, where they're going to end up practicing. Because if they have the ability, they're going to move to a state that has full practice authority. So not only is it expanding your current pool, but it's also expanding your future pool. So thank you all, and thank you to the PACHA folks who have supported all of the comments about nurse practitioners and the strengths that they bring to the HIV response. So yes, I'm going to talk about nurses. That's my job.
You're going to always give us nursing, and we love it. Absolutely love it. Duvia.
Thank you so much. I want to congratulate the panel. It was amazing. It was so insightful. I'm a note taker, and I have about 5 pages of notes that I took. Your recommendations were phenomenal. I want to also appreciate DeAndre for your vulnerability and sharing your story. Thank you so much. That really, to me, it's very heartfelt, and it's what we deal with in our African-American, Black communities and Latino communities. So thank you so much for reminding us that we are in this space because we care about each individual. And I want to appreciate Judith and Linda Dixon for reminding us of the long-term societal and economic cost of neglecting the intersection of HIV stigma and the social determinants of health, and also Medicaid expansion. Can you tell us what your recommendations are on how we can develop healthcare policies that can be adjusted to address the social and structural factors that contribute to the spread of HIV, the persistence of stigma in the South for Black and Latinx communities? So what are your recommendations on maybe some healthcare policies, if anybody wants to address that? And that's not just specific to Judith, and please feel free, Dr. Eaton, I know you did such an amazing job also addressing healthcare, the intersectionality of healthcare. So please, anybody on the panel, feel free to jump in and give us some recommendations.
So thank you for that question. I think there's so many different, it's a loaded question. We could, the list is long, I'm trying to narrow it down. But the first thing that comes to mind is being able to incorporate cultural sensitivity. I think that would go a long way across the board in a lot of different ways. I think about stigma and how we need to look at practices in everything that we do, whether it's delivery of care. I think we need to have more holistic approaches to how we take care of and love and advocate for people with HIV. In Mississippi, we have an HIV medical legal partnership. And it's a novel approach to providing medical care and legal assistance and support to someone living with HIV. You don't know you have a legal issue until you have a legal issue. So we actually work with providers who can, identify some things that may rise to the level of a legal issue and help to support that person, because everyone is not just their status. I mean, you come with the same things that anyone else comes with. You may have a housing issue, or you may have, a predatory issue or an expungement you need to help, you get a better job or to get a job. So I think employing more holistic approaches to how we provide care and services to people with HIV.
I think additionally, the support and leadership for Latinx folks. In North Carolina, there is one AIDS service organization with an executive director that is Latino. His name is Antonio del Toro, in Western North Carolina AIDS Project. From there, I don't know of any other Latino AIDS service organization or AIDS service organization that has a Latino as the executive director, excluding Texas and Florida again. And so there used to be one in New Orleans, Stephen Rivera, who passed away in 2021 at Project Lazarus. And so there's a real lack of opportunity and leadership where we do need further investment in organizations and in individuals to be able to respond and not be seen for a lot of Latinos who are line staff, right? And so folks who are outreach workers, who are managers, but they're never executive directors. And so we know that our communities know how to understand and respond to the HIV epidemic. And there's a lot of grassroots organizations, working to fight for equitable access to healthcare for people living with HIV. And they are severely under-resourced. And the investment in their leadership is just not there, at least not on the federal level.
Yeah. I'll just add to, if there's a way to streamline access to antiretroviral therapy across the South, that is definitely an area that needs to happen. Whereas in Louisiana, I have some flexibility in terms of access, that may not necessarily be the same or the case for the surrounding states. And so, well, what does that mean? That means that, we may be able to get people virally suppressed in Louisiana, but it doesn't really matter because everything around us, you're not able to get people what they need. And so they may not necessarily achieve virus suppression. And so we don't get to the point where we're able to end the HIV epidemic because there's all of these differences in what patients have access to and how they can get it. So a way to like if we look at that map and you can see all the different states that are not Medicaid expanded, to figure out a way to elevate that. And if Medicaid is the way to cover the cost of antiretroviral therapy, then, we certainly need to be looking forward to try to figure out a way to make that happen. But then it's also the other services that Medicaid supports. So sometimes there can be challenges. I recall when I was working in the northern part of the state, there was Medicaid transportation. So there were few companies that were providing the Medicaid transportation service. And so the company was employing drivers that were bringing patients to the clinic, but then the drivers were going back into the community and telling the people in the community where they were taking people. So there's some challenges, and then that goes right back to stigma. So now we're right back to square one with stigma. But I think we got to also look really closely at the other services too within the model of what Medicaid provides, and making sure that there are safeguards and things in place that have appropriate and ethical people working to provide those services. Thank you.
Great, but thank you for your question. I think just as a follow-up to my suggested solution for integrating care, we really have to incentivize both the providers and clinics who we're asking to take on additional HIV prevention, harm reduction services. And that starts with loan repayment, and it starts with incorporating substance use and mental health into the curriculum for all of our nurses and all of our ID docs and all of our general internists. And then at the clinic level, a Ryan White type model, for example, for my general infectious diseases clinic, where people come after their endocarditis and we treat this life-threatening infection, but there is no incentive for the provider then to take it to the next level and appreciate that their active fentanyl injection is going to continue to put them at risk, and really empower that clinician and clinic to embrace and own those conditions, social determinants of health, that put people at risk for HIV in the first place. So a lot to unpack there, but that's
amazing recommendations that hopefully we can take some action on. Mo.
Rania, can I speak, or is there someone else in queue?
Go ahead, Lauren.
Thanks. I just want to bring this back to housing. If we have 1 in 4 people living with HIV who aren't stably housed or who are homeless, I think we also need to think about ways that we can reach out to people and not expect them to come to medical systems. And that this is exactly why there has been low uptake on for PrEP for a lot of Black and brown persons and transgender persons, and also adherence to medication, as the data show. So knowing about the transportation barriers, hearing that weird clinic hours that Judith just shared, there are providers like healthcare for the homeless in big cities. But what are ways that we can do that in the South and take the medical system out to people and get really innovative? I'm thinking of midwives and how midwives are so critical in reducing mortality for Black women, especially in the South, and the midwives movement in Alabama, and ways that we can empower community pharmacists and other people to provide care, that it doesn't have to be so medicalized, which means really thinking outside the box, and yes, thinking of who was paying for these services. I get it. But that is something we need to think about if 1 in 4 people in the South basically live under a bridge or transient.
I know it's 1 minute to the 30. You know how. Oh, thank you, twin brother. 2 minutes. Okay, good. First of all, I'd like to challenge all of us to take each presentation to our networks to highlight the visibility and the challenges of the South, number 1. And number 2, if someone could share with us what from the South perspective, the domino effect, positive or negative, of the expansion of Medicaid in North Carolina. And I understand its challenges because, it's dynamics, but I think it's hope. And I always like to see the glass, half full, and more than ever. And again, especially my Reverend Banks there, love you, and Marmina Miller, they did the efforts to stay presented, to show up, and bring your voices. And we recognize each of you and all the presenters. Thank you.
So fortunately, North Carolina is a bellwether state in Medicaid expansion in the South. And so we know that organizations like Care for Carolina are working closely in Mississippi, in Alabama, in other states to share some of their best practices, what the strategies were and we were part of that coalition for 10 years. And so we also know that some of our legislators who champion Medicaid expansion in North Carolina have also made calls to other legislators in other states to share perspectives, right? However, the expansion of Medicaid in North Carolina has also left some moments for governors of some of these states to share on social media their thoughts about Medicaid expansion that are not positive, and sort of rally up folks to be against expansion efforts. I don't know if Linda, you want to?
Which, we have to get ahead and create our own narratives, because we know that in states that have expanded Medicaid, people living with HIV have fared out far greater and better than non-expansion states. And so I think if we look at all the positive things that we know is going to happen, and I've already stated some of them, but just, when we just look at the overall health and well-being of the people that would benefit from this is, of course, priority. And you look at the financial component of not only just building the infrastructure for healthcare, but it's job creation, right? And being able to keep hospitals open and expand services to people. So I think we get ahead of the narrative and create our own and look at all the benefits and the financial component of expanded Medicaid. And can I just add to, and I appreciate you mentioning, Judith, how the states have really tried to support each other in the Southerners for Medicaid expansion, and just being able to share experiences and communication tactics and things of that nature. So we are surely better together. And Southern states, we look alike. We just cross different borders. So it's been wonderful to have that type of regional support. And so, and I appreciate you saying Mississippi's next. Ooh, that would be great. But, and we applaud those who have come before us. So we're going to keep plugging away until every state in this country has expanded Medicaid to people who need it.
Thank you. Jesse, I believe you sure? Okay. Nope. Oh.
Can I jump in here real quick if we got enough time, y'all?
Go ahead.
Okay, cool. Thank you so much, DeAndre. I just wanted to bring us back home to MIPA, the meaningful involvement of people living with HIV. I would be remiss if I did not mention, when we're talking about creating solutions, talking about investing in the leadership and the development of leadership of people living with HIV. I sit at this seat as a person living with HIV because of those who came before me that took up on the leadership mantles of people living with HIV-led networks. And so to really address a lot of the common issues that typically happen in the HIV AIDS space, we must know that unless you are a white gay man, these systems were not created for you. They weren't created for women. They weren't created really for Latinx people. They weren't created with us in mind. And so in order for us to really take up the mantle and think about how we are prioritizing people most impacted by the epidemic, and in order to end the HIV epidemic, we must center the leadership and the leadership development of people living with HIV and create initiatives specifically designed to nurture and elevate the leadership of Black and Latinx communities, equipping them with the tools, the training, and the opportunities necessary to really take up these decision-making roles, and putting people living with HIV in every level of leadership in an organization, from the executive leadership all the way down to peer support. And although I love peer support work, we cannot keep putting people living with HIV just in peer support roles. They need to be at every level of decision-making in clinics to be able to provide great healthcare and great health outcomes for people living with HIV, because they know what they need. This epidemic was started, and the activism around this was started by people living with HIV. And so really funding community-led initiatives is what's going to get us out of this epidemic. I just wanted to input that before we end it.
Thank you. Thank you.
Marnina, thank you so much for closing us out. I think closing us out with such a powerful charge. Thank you again to the amazing panel. Thank you to PACHA leadership. Thank you to my co-moderator, DeAndre. This has been a great panel, and I will hand it back over to Chairperson McNeese.
Thank you, Rania and DeAndre, for this outstanding panel. I will not hold us too much longer, as DeAndre's stomach is touching his back. So we will reconvene at 12:30, where we have another equally exciting discussion. So back at 12:30. Thank you, everyone.